Garima is ready. No, just wait 1 minute. Gori Gattani, okay. Jyoti Sakarwal, good. Maya Hada, good. Mukesh Prakash Patil, Nidhi Pahadia, Pooja Kesarwani, Poonam Jain, good. Pratik Jain, very good. Rasik Priya Sandhu, good. Sandeep Chaudhary, Shanti Priya, Sonal Agrawal, Surbhi Khandelwal. We'll start within 2 minutes. Garima, your presentation is ready? Okay. Everybody is requested to upload their presentation. Thank you, Beta. And Gori Gattani should be ready on the other podium to save the time.
A very good morning, everyone. The topic of my presentation is dry eye disease in menopausal and postmenopausal women. Dry eye is a tear film problem due to inadequate or excessive tear production, which harms the interpalpable ocular surface and causes irritation in the eyes. Postmenopausal women experience dry eye syndrome due to modifications in the equilibrium of sex hormones, which are produced and maintained by estrogens and androgens. A drop in hormone level, alterations in feedback process, and shift in receptor responsiveness modifies the homeostasis of the ocular system, leading to dry eye, especially in postmenopausal women. The symptoms being tearing, redness, pain, burning, and vision abnormalities. If neglected, can lead to a variety of complications like bacterial and viral infections, ulcers, scarring, staphylomas, and even blindness. In our study, we included 100 postmenopausal women. It was a cross sectional study, and we excluded women who already had dry eye from illness due to other reasons and contact lens wearers. A Shermer's test and a semi structured questionnaire was prepared. Pathological values less than 15 mm were considered to have dry eye, values of 10 mm being suspicious of dry eye, and pathological values of 5 mm or less were considered dry eyes. Eye itching was the most common symptom experienced in a study, which was 45%. The average age of the study population was 51.66 plus minus 5.8 years. The mean age at menopause was 45.63 plus minus 1.8 years, and overall prevalence was 48%. This is the pie chart showing 52% normal women and 48% having dry eyes. The correlation of age and dry eye disease was positively correlated in a study, with 22% of women in more than 50 years age group having dry eye syndrome. The different demographic variables in a study were urban population with 78% postmenopausal women having dry eye. The literate component had dry eye in 80% of population. Housewives and employed had 68% of dry eyes. The upper socioeconomic position people had postmenopausal women had 83% of dry eyes. So the prevalence of dry eye illness in postmenopausal women were positively correlated and were statistically significant for two variables, that is postmenopausal women over the age of 50 years and the women who were employed. So our study had prevalence of dry eye in postmenopausal women 39%, which was similar to a study done by Aditya et al. And Adlaka et al., but it contrasted in comparison to a study done in Japan and Moss et al. The dry eye syndromes in a study was 27%, which was experienced, which was in contrast with a study done in China and Ukino et al. The mean age of postmenopausal women in our study was 51.6, which was very similar to Moss et al., but it contrasted with a study done by Ukino et al. And Albots et al. The relationship of dry eye with increasing age had a strong correlation, which was similar like Adam et al. And Australian study. So our study, we had positive correlation with working women and socioeconomic status, which was statistically significant, and it was added with studies done in China and US. So concluding my study, postmenopausal women had dry eye syndrome, which was positively correlated with age, urban lifestyle, literacy level, socioeconomic status, and the occupation. So my take home message would be awareness of the disease and encouragement to seek medical help leads to early diagnosis by a simple Shermer's test for screening, and it can lead to improvement in the quality of life as early treatment can be started. Thank you so much.
Thank you, Dr. Garima. But what was the reason to conduct this study? It is a known fact that the menopausal, postmenopausal females have a dry eye.
So the basic concept in the study was they had dry eyes, but we wanted to see the other variables as well, like the socio-economic status, like the age, like the employment. The employed women had more number of dry eyes, and the literacy level also. So we wanted to compare other variables in that age group.
But what was the difference you have shown?
So the statistically difference, the positive difference that we got was with the increasing age, the postmenopausal women above the age of 50 and 55 years had more dry eyes, and the employed and the literate were more having the dry eye syndrome. That was in the percentage of 22% and 80% in the socioeconomic status.
You did not take women on HRT therapy in your group, no?
Yes, sir. So we excluded all other women which had dry eyes due to other reasons and contact lens wearers as well, sir.
All right. That would have been of more use if you would have included that group also. All right. Thank you.
Thank you, sir.
And Shermer's is not enough to diagnose the dry eye. It was
Sir,
Shermer 1 or Shermer 2?
Sir, is what Shermer 2, but what happened was we had to recruit 100 postmenopausal women. So it was very difficult to recruit them to the OPD. So we went to the Obs-Gynae OPD and we did alongside the Shermer's test. So other tests we could not perform, sir.
No, but to have data on the dry eye with such low number, it cannot be given importance. But well done. Well done.
Thank you so much.
Thank you. So, yours is? No worry. So now we invite the next presenter, Dr. Gauri Gattani. She is going to speak on wide field imaging, a boon to anterior segment surgeons. Yeah, start, please.
Good morning, everyone. So today I'll be speaking about how wide field fundus imaging has proved to be a boon to an anterior segment surgeon like me. This pie chart shows the prevalence of retinal diseases in general ophthalmic OPD, and we see that it is pretty significant. And many of these pathologies might be missed if the peripheries are not examined, as a study found that 66.4% of retinal findings might be found outside of the 60 degree of the optic nerve head. So many of the anterior segment surgeons like me might not be performing indirect ophthalmoscopy of every patient coming to the OPD on a daily basis. And even if we do, we might not be getting the perfect 360-degree view of the peripheries. And hence we resort to 90D examination, missing many pathologies. So the International Wide Field Imaging Study Group defines posterior pole as the area between the temporal arcades, and the wide field as the area posterior to the 4 vortex veins, and ultra wide field as the area anterior to the 4 vortex veins. In my study here, I have used a scanning laser ophthalmoscopy based wide field imaging system of Nidec Mirante. So I'll go in brief about how it has helped me uncover some pathologies. This gentleman, chronic narrow angle glaucoma patient, came to me. He was not a known diabetic and was last dilated 8 years ago, and he was diagnosed to have NPDR with undilated wide field imaging. Another example is of a 45-year-old bank professional who came to me to the OPD with a history of few days of diminished vision. At that time, our VIA surgeon was in OT, so though with my fundus examination, I could clearly see the retinal detachment, but with the advent of wide field imaging, I could also localize the small superior hole, which was beautifully following the Linkoff's rule. This is the third example of a routine examination of a young emmetropic patient, and I could see small peripheral hole which I had not seen on my fundus examination. Another example of a 14-year-old young myope who came for routine examination, and I could see she had exam next day and was not ready to be dilated. But with wide field imaging, I could see she had a lattice with a hole, and hence she was referred to the retina department. Now I'll tell you about how it's impacting my cataract surgeries. This gentleman was a known glaucomatous patient with recent history of diminution of vision and was advised cataract surgery elsewhere with a small grade of cataract. On wide field imaging, I could see he also had CRVO, which was previously undiagnosed, as the hemorrhages were mainly in the periphery. Another example of a 49-year-old male who came for cataract surgery and was detected to have a large peripheral lattice, and hence I referred him to retina before proceeding with the cataract surgery. This 32-year-old myopic female came to me for second opinion as she was advised prophylactic laser elsewhere. On wide field imaging, I could see she had peripheral paving stone degeneration, and we realized that we could just keep her on monitoring. A little in brief about how the patient gets engaged with their own disease with the help of wide field imaging. So these two are different patients, very old patients who were buckled by our own senior surgeon around 15 years ago. They kept coming for regular follow-up, and with wide field imaging, this was very reassuring to them to see their retinas nicely buckled. This patient complained of persistent black spots in vision, and he was very, very bothered by them. So on showing him on the wide field imaging, his floaters clearly, it was very easy to counsel him. Another patient who came with sudden loss of vision many years post cataract surgery. So with wide field imaging, we could show him the exact cause of his diminished vision. This example is of a 60-year-old male who had history of nyctalopia, and he was searching everywhere for a cure of nyctalopia, and he was clueless about his own disease. So wide field imaging helped us counsel him, and it gave him acceptance towards his own disease. This was a 17-year-old girl who knew that she had lattices, and she had been to multiple centers, and she was just bubbling with Google knowledge, and we could satisfy her curiosity when we showed her the lattice. So a study done in 2022 has showed that indirect ophthalmoscopy clinical grading and imaging by wide field fundoscopy did not have much significant difference, and the diagnostic potential was almost similar. Rather, the wide field imaging proved more efficient because the time required for wide field imaging was less, and it could be done by a technician, whereas the indirect has to be done by a doctor. Wide field could also be performed on an undilated pupil, unlike IDEO, and education and training of staff as well as residents is much more better with wide field imaging. And also, in the absence of a readily available VR person, it's very useful for telemedicine. Thank you.
Nice presentation, Dr. Gauri.
Thank you, sir.
Is there any disadvantage or cost restraint of this particular imaging technology? Because
Disadvantage, sir.
is there any like?
So, firstly, the cost, definitely.
Yeah. So
And
how much is the cost? Approximately.
sir, this one we have is without the ICG system, and it costed around 90 lakhs. Sir.
Okay.
And also, sir, the bright light. Some patients are very bothered by the bright light at the time of imaging, though it lasts around 2 seconds. But
What is the Linkoff's rule?
so Linkoff's rule is helps us to localize the point of defect, whether it's a tear or a hole in the retina, in relation to the retinal detachment.
So where it is?
So according to the different retinal detachment positions, we can
No,
hypothesize.
you mentioned in one picture that
Yes,
the
sir.
detachment was inferior and hole was superior.
Yes, sir.
So what is the range? Linkoff rules, it should be within 1.5 clock hours
Okay.
of the detachment. Okay. So it was a good presentation, but I think for competitive paper, you should have some study kind of thing
Yes.
where you can present your data.
Yes.
Thank you very much.
Thank you, sir.
Now we invite Dr. Dirgha Parikh. She will speak on customized toric IOL implantation in cataract patients with high corneal astigmatism, a case series.
Good morning, everyone. Myself, Dr. Dirgha Parekh. The topic for my presentation is customized toric IOL implantation in patients with high corneal astigmatism with cataract. High corneal astigmatism can be a result of corneal surgery and several other corneal conditions. Implantation of toric IOL can be employed for correction of corneal astigmatism in cataract patients. Most of the commercially available toric IOLs can correct up to 6 diopters of astigmatism. However, for astigmatism more than 6 diopters, regular toric IOLs may not serve the purpose, and there may be a need for an IOL with higher toricity. Aim and objective of this study is to analyze the outcomes of phacoemulsification with high power customized toric IOL implantation in patients with high corneal astigmatism. It is a retrospective case series conducted in last 1 year, including 12 eyes of 9 patients. All cataract patients with high corneal astigmatism have been included in the study. The exclusion criteria includes any other visually significant ocular comorbidity, any previous ocular surgery other than corneal transplantation, corneal tear repair, previous refractive laser surgery. All patients underwent comprehensive pre-operative assessment, which included slit lamp examination, tonometry, and dilated fundus examination. Uncorrected and best corrected distance visual acuities were recorded at the baseline visit, along with manifest refraction. Pre-operative investigations included topography, IOL master, anterior segment OCT, and specular microscopy. All procedures were performed under topical anesthesia. Phacoemulsification with Altima smart toric IOL implantation was done in all patients. A toric IOL online calculator and ordering system provided by the manufacturer were used to calculate the IOL power. Horizontal axis was marked at the slit lamp with a surgical marking pen at 3 and 9 o'clock positions. A temporal 2.8 mm incision was used in all cases. After phacoemulsification, IOL was injected in the bag and in position to obtain a precise alignment of IOL axis marks with the marking done preoperatively. All patients were followed at 1 day, 1 week, and 1 month post-operatively. Longer follow-up appointments were scheduled when possible. Outcome measures included uncorrected and best corrected distance visual acuities, manifest refraction, and IOL stability at last follow-up visit. Slit lamp examination, tonometry, and fundoscopy were also performed post-operatively. Snellen's visual acuities were converted to logMAR values. Results were the study included 12 eyes of 9 patients. All the surgeries were uneventful. Mean age of patients was 47.77 years. 8 out of 9 patients were males. Mean pre-operative uncorrected distance vision was 1.06 with 0.48 standard deviation logMAR units. Mean follow-up time was 4.72 months. At the last follow-up, there was a significant improvement of uncorrected vision, best corrected vision, and cylindrical refraction. IOL was stable at 180 degrees axis in 100% of eyes. And these are the values comparing pre-op and post-op visions and cylindrical refraction with their p-value. Correction of high astigmatism in cataract patients continues to be challenging. Post-cataract surgery rehabilitation with spectacles or contact lens wear often fail due to anisometropia, high astigmatism, or intolerance to contact lens wear. Implantation of toric IOL up to 6 diopters is a safe, predictable, and effective alternative. For astigmatism more than 6 diopters, customized toric IOLs have been employed. The role of toric IOLs in cataract surgery of post-keratoplasty and keratoconic eyes has been examined in a few small case series and reports. A range of different corneal conditions responsible for high cylindrical refraction was treated in our series. In our case series, cataract surgery with a high-power toric IOL was shown to be both safe and effective in correcting high values of corneal astigmatism in the presence of visually significant cataract. To conclude, customized toric IOL is a safe option in patients of cataract with high corneal astigmatism with effective and predictable outcomes. Thank you.
Thank you. Nice presentation.
Thank you, sir.
Like out of your 12 eyes, maximum indication was of which disease?
So most of them were corneal ectasias, most of which was keratoconus. 2 eyes were of pellucid marginal degeneration.
All right. And these keratoconic eyes, like, were the C3R or stabilization done in all earlier, or?
No, sir. In one eye, there was bilateral to customized toric IOL implantation. In one of the 2 eyes was post C3R treated eye.
Mhm.
Yes.
You said that the patients were keratoconus and pellucid marginal.
Yes, sir.
So how you decided the actual axis you want to implant?
So the axis was decided only on the basis of the manufacturer.
No. Keratoconus does not have one fixed axis to have a astigmatism correction. Otherwise, they can improve eyeglasses. So how it was decided?
So the axis and IOL power and the cylindrical refraction, the post-op.
No, I'm asking simple.
See, in keratoconus, there are sometimes gross problems.
Yes, sir.
The cylinder which you get on AR is very different from the subjective axis which patient is accepting.
Right,
And
sir.
at times it is difference, the difference may be of more than 30-40 degrees. So very difficult to choose the axis, which one you preferred, basically in these cases. So what was your take? Like, did you take
On the
axis on the based of
topography, sir.
topography?
Yes, sir.
So there were similarity on topography and AR or IL master or whatever optical biometer you
No,
use.
sir, they were different.
So
But
how you chosen? That is what I am asking.
sir, in such cases, topography was the final determining factor.
Okay. Ideally, when we do toric lenses, the patient should be made aware that in keratoconus patients, you will not get what we are thinking that toric will improve their vision. What was your visual outcome in keratoconus patients post-op?
Sir, visual outcome did improve. Like there was a significant improvement. Vision did improve in some of the patients up to 6/9 or 6/12 post-operative.
So what was the pre-op refractive error?
Pre-operative-
Astigmatism side in this patient?
Pre-operatively, many of them had a vision of 660
No,
or
cylinder. How much was the cylinder?
sir around minus 5.5. There was a ectatic patient with a cylinder as high as -9, sir.
You have not shown the topographies, but good way. So the take-home message should be that in patients with keratoconus and PMCD, it is difficult to decide what axis we should choose for implanting the IOL, and the results may not be up to expectation of yourself and patient. So be cautious that patient should be made aware that he or she may require astigmatism correction later on also by means of refractive glasses, sometime contact lenses, and it becomes difficult to correct them by contact lens if you have implanted a toric lens inside, because once toric lens is inside you can correct the contact cylinder by uh, contact lenses like a minuscule or RGP or Rose K or whatever kind of lenses, but then the toric lens will behave like a cylindrical power. Thank you.
Thank you, sir.
So next we have
Dr. Jyoti.
Dr. Jyoti Sakarwal.
Yes.
You are going to speak on profile and surgical outcome of pediatric cataract at a tertiary care teaching institute.
Yes,
Okay.
sir.
So please start.
A very good morning to all. So the topic of my study was profile and surgical outcomes of pediatric cataract at a tertiary care teaching institute. As we all know, pediatric cataract is a major cause of preventable childhood visual impairment and blindness. So, the study was done to provide a glimpse into the disease burden in Western Rajasthan, as well as to evaluate the outcomes and profile of congenital and developmental pediatric cataract at a tertiary care hospital. This was a prospective international study. It was done at AIIMS Jodhpur. The sample size was 63 eyes of 33 patients with a minimum follow-up of 12 months. All patients with age less than or equals to 12 years with unilateral or bilateral visually significant congenital or developmental cataract was included in the study. So coming to the result, the mean age of the patient at the time of first symptom detection was around 5 years, and the mean age at the time of surgery was near approximately 6 years. The family history was seen around 22% of the patient, and history of consanguineous marriage was seen in 15% of the patient. There was a history of premature birth and low birth weight in 6% of the patient, and NICU stay history was seen in 12% of the patient. Coming to the etiology, majority of our patients, 84% patients were idiopathic, and followed by the next cause, hereditary, which was seen in 13% of the patients. 94% of the cases were having no associated findings systemically or in the eye. We do have one patient of torch and one patient of rubella each. One patient was having microspherophakia in both eye. Coming to the gender, we had male preponderance with majority of the patients, 70% of the patient presented were male. Majority of patients had bilateral presentation, 90% patient had bilateral disease presentation. Coming to age-wise distribution of the disease, the mean age was although 6 years, but we have majority of the patient between 3 to 12 years of the age group, near about 70 to 80%. We have only 4 patients with less than 1 year of the age group. The first symptom noted was whitish reflex in 44% of the patients, followed by second common cause, deviation of eyes, followed by abnormal ocular movements, and 13% of patients were referred by other doctors. The first person to detect were parents in 67% of the patient. Next common was pediatrician in 24% of the patient, and few patients were detected by relatives and teachers. Coming to on inquiring about the causes of surgical delay, 44% of the patient were misread by local practitioners, and 31% patient had reluctance for surgery, and 25% patient felt no delay at all. Coming to morphology of the cataract, the most common morphology we found in our patient was lamellar, which was seen in 55% of the patient, followed by nuclear cataract, total, and few patients had membranous and posterior subcapsular cataract. Coming to intra findings, we had posterior capsular plaque in 5 patients, anterior capsular plaque in 5 eyes only, sorry, and anterior capsular plaque was seen in only 4 eyes, and pre-existing posterior capsular defect in only 3 eyes. Coming to comparison of visual outcomes, visual acuity was less than 660 preoperatively in 39 out of 42 patients, which was only seen in 5 patients out of 47 after surgery. Near patient was more than or equals to N18 in 26 patients out of 32, and the fixation was central and maintained in 15 patients out of 16 postoperatively. On comparing the axial length on follow-up, we found a significant axial length difference at 1 year in less than 1 year and 1 to 2 year of age group, but it was not significantly changed in 3 to 5 years of the patient. Coming to keratometry, there was significant change in less than 1 year, but in 1 to 5 year of 1 to 2 and 3 to 5 year of the age group, the keratometry did not change significantly. On comparing our study with the other Indian data, we found we have a mean age of presentation a bit more than the North India and South India study. We had 6 year of mean age presentation. We have more developmental cataracts. We have more patients with bilateral presentation. That was 91%. The most common morphology we had was lamellar cataract, and visual acuity outcomes was more than 660 in near about 90% of the patient. So to summarize, the mean age of presentation was higher with male preponderance. The most common type of cataract was lamellar cataract. There was a strong negative correlation between age and day 1 postoperative refraction. Our patient eyes seem to have a smaller change in myometry, especially in less than 2 years. Around 84% of the patient reported improvement in their child visual acuity or school performance. We do have limitations. We have a small sample size with a short follow-up of only 1 year. These eyes obviously should be followed for a more duration. We did not include traumatic cataracts. So to conclude, in our region, there is a need for education and awareness on pediatric cataract to tell them that the disease is treatable, there is good visual outcomes if the disease is treated early. To improve early case detection and referral services with expertise in the assessment, surgical treatment, and long-term management of the child with cataract. Thank you.
Nice presentation, Dr. Sakarwal.
Thank you, sir.
I've got few questions.
Yes, sir.
One is that how did you check your data in these patients vis-a-vis keratometry, A scan, and vision?
So A scan was done by contact, axial length. So all this biometry was done under EUA, examination under anesthesia. So keratometry was done by handheld keratometer, NIDEC. And A scan for axial length, yes, of course, sir, it was we measured from the cornea. So it was a contact procedure.
Okay.
We do have some, we can measure axial length from the anterior surface of the cornea till this posterior retina. And second, so vision. The thirdly was for vision. Yes, sir. So the vision was done with ETDRS chart in those patients who are able to tell vision. Yes, of course, sir. In like more than 3 years, patients were able to tell vision accurately. And in smaller patients, we check, sir, quantitatively, not the qualitatively data,
But
fixation.
you, in your data analysis, you have taken all patients. You are saying 84 or 74. I have forgot the exact the data which you said. has
Sir, for
improved
vision?
to N8 or something like that.
Sir,
You only
that was,
spoke.
yes, sir, majority of the patient
No, but
are
you
more than
don't
3
go
years.
by, huh?
Majority of our patient are more than 3 years, sir. We
No,
have
what
very
majority?
special.
By three,
80%.
less than one. Yes, less than 1 year was 3 patients in your
Yes, sir.
study.
Yes, sir.
And then less than 3 years also were, some of the patients were
Yes,
less
sir.
than 3 years.
Yes, sir.
So my question is that their data you have included in your presentation, data analysis.
But not for sir vision.
No, in vision also.
You mentioned.
You
Sir,
mentioned.
that was eyes. We have total 66 eyes. So that was eyes. So 66 eyes were total analyzed. So out of 66, near about 46 eyes were. So 46 eyes were given for the
Analyzed.
visual. Yes,
So
sir.
what was the age
analyzed.
of these 46 eyes?
So they all are more than 3 years. Less
So,
than
but
3
at
years, so
3
we were
also
not
they can't
able
treat.
to.
At the 3 also they can't treat.
Sir,
Okay. So what was the surgical protocol you used?
so the surgical protocol we are using is if the in less than 1 years, if the axial length is more than 18 mm, or if the white to white is more than 10 or around, so we are planning to put IOL. So in less
Okay.
than 1 year, we are doing 20% under correction. In 1 to 2 year, we are following 15 years. So we are following a study done by Dr. Coker sir at IP Center because they are reducing the amount of under correction. So in 1 to 2 year, near about 15%, and 2 to 5% depends between 5 to 10%, sir. Depending,
Okay.
of course, depending on
Okay.
axial
Which
length
IOL
and-
you have used?
Sir, Techness,
Okay.
Johnson's and Johnson's
Ah.
foldable.
You have done
I think-
primary capsule access in the
Yes,
posterior
sir.
capsule?
Yes, sir. In
In
less
all
than 5
patients?
years, in less than 5 years, I
Okay.
have done PCC with anterior vitrectomy.
Hmm.
In 5 to 7 year, only PCC, and more than 7 years, sir, no PCC.
Okay. How many patients were more than 5 years?
Sir, more than 5 years, 79%. So that is the thing. The patients are coming to us with higher age group. That's, sir. I was at RP Center. The patients there.
Somebody getting operate after 5 years, not having bilateral cataract, will have amblyopia.
So
You re-
unilateral, we have 4 patients.
You have recovered vision in all.
No, so the unilateral patients had dense amblyopia. In
So
one
that
patient,
should be
even
there
the-
here.
In one patient, even the fixation did not come back.
No, so
That
that
was-
should be reflected in your data.
Okay, sir.
What you are keeping with you is not visible here.
Only the
So it
things.
doesn't make that sense in that sense. It should be very clearly visible. The patient less than 3 years, this was the visual outcome.
Yes, sir.
These were the complications. 3
And
to
yes,
5,
sir,
this
I
was the
could have,
outcome.
classified
Patient getting
this.
operate after 5 years will have, even after 3 years also will have dense amblyopia.
Yes, sir, definitely.
And your follow-up is short.
Yes, sir.
So,
Only 1 year.
so they
sir.
can't improve on amblyopia
So
part.
we are still following up these
Okay,
patients.
what was the amblyopia treatment protocol followed?
So in unilateral patient, we prescribe patching in all the patient after glasses. So the same, sir, up to 6 year, like 1:1, 2:1, according to age. Then till 6 years, 6:1, and after that, we will continue with 6:1 patching.
Okay.
Thank you,
Thank
sir.
All single piece lenses you implanted.
Sorry, sir.
All lenses were single piece.
Yes, sir.
Okay. Thank you. So now I invite Dr. Maya Hada to speak on periorbital necrotizing fasciitis, clinical microbiological profile and outcome in 14 cases.
Thank you, sir.
Good.
So I have no financial disclosures to make. We know necrotizing fasciitis is a life-threatening condition of the subcutaneous tissue that mainly affects the abdominal wall and the limbs. It is rare to occur in periorbital region, but it can lead to significant ocular morbidity and facial disfigurement. So we present a series of 14 cases of this entity. The diagnosis was entirely based on the clinical presentation, that is, the rapid spread of cellulitis in the subcutaneous tissue of the eyelid and periorbital region associated with necrosis. We collected the baseline data, including the clinical presentation and microbiological and radiological results of the patients. So 14 patients were studied. Mean age of the presentation was 17 years, and 8 patients were below 5 years of age, and 64% of the patients were males. The etiology was preceding injury was seen in 4 cases, as preceding infection was seen in 5 cases, and it was otitis externa, erysipelas, and sinusitis in 1 case each. This was the case associated with streptococcal skin infection in a 2-year-old male, which was followed by PONF. This was the periocular infection, perichondritis, in a 2-year-old male, which was followed by PONF. And it was a case of insect bite, which was followed by PONF. Clinical presentation, the most common symptom was periorbital pain in 78%, and the most common sign was tense cyanotic eyelid edema in 92% of the patients.
The extent of involvement was the periocular region alone in 9 cases. Facial involvement was seen in 4 cases, and orbital involvement was also seen in 1 case. We calculated the LRI NEC score, that is a laboratory risk indicator for necrotizing fasciitis, and correlate it with the extent of involvement. The mean LRI NEC score was 1.12, and significant correlation was noted with the extent of involvement. Our 6 patients were chronic immunocompromised, and that includes poorly controlled diabetes, hematological malignancy, chronic alcoholic liver disease, and JRA with oral steroids in 1 patient. All cases received IV antibiotics and underwent surgical debridement. IV immunoglobulin was also given in 2 cases who were immunocompromised, and orbital exenteration was done in 1 case. Reconstructive surgeries and full thickness graft was needed in 12 cases. Vision loss occurred in 4, and 1 patient succumbed to the disease. The most common isolated bacteria was group A beta hemolyticus streptococcus, which was there in 9 cases out of 14. Now, discussing the cases individually, this was the patient with chronic alcoholic liver disease and systemic shock. He came to us with right PONF and facial involvement. Repeated surgical debridement was done. The extent was noted going up to the temporal fossa and till the mandible. Because of the poorly controlled systemic status, hypoproteinemia, electrolyte imbalance, he was also given IV immunoglobulin and IV antibiotics, and he recovered well after full thickness skin graft and reconstructive surgery. He attained good cosmosis. However, there was a decreased vision in that eye. This was the poorly controlled diabetic female who presented to us with bilateral PONF. She also received IV immunoglobulin in addition to antibiotics and debridement, recovered well with some scarring. This patient was having myelodysplasia, and he was a recipient of bone marrow transplant, underwent orbital exenteration. However, he succumbed to the disease by multi-organ failure. This patient was poorly controlled diabetic. However, he recovered well after IV antibiotics and debridement. This was a young female. She presented after minor trauma and cutaneous gangrene, recovered well. Young male, he also recovered well. Now we have a large series of pediatric patients in our series, and they all underwent multiple surgical debridement. Most of them had upper lid cicatricial ectropion, for which they have to underwent full thickness skin grafting. However, some leg of thalmos was seen residually in most of the cases, but the eye was salvaged. So, as per the available literature, PONF is essentially a disease of adults, with average age of being presentation reported as 50 years. In our series, 8 patients were below 5 years of age. We suggest that we should have a high index of suspicion in children presenting with preseptal or orbital cellulitis, and we found the mortality rate in our study being 7%, which was comparable with the available literature. And we also support that PONF has a relatively better outcome and lower mortality than the necrotizing fasciitis elsewhere in the body. Our series highlights that PONF can be well managed with early recognition of disease, prompt debridement, and aggressive antimicrobial therapy, and whenever needed, IV immunoglobulin. And to the best of our knowledge, this is the largest series of PONF from the Asia Pacific region. These are my references. Thank you very much.
Very nice presentation, Dr. Maya. One question is that what treatment protocol you followed in these cases? Were there a set protocol, or you varied your protocol according to the patient?
So there was a set protocol. We followed the broader spectrum antibiotics, vancomycin with ceftriaxone in all the patients. And if our culture report supported that the patient is not sensitive to that, then we switched our antibiotics accordingly. But we started with vancomycin and ceftriaxone in all cases.
And the average duration of antibiotic and average hospital stay was?
The average duration was 7 days. And in some patients who were poorly having immunocompromised status, they also received IV immunoglobulin for additional 5 days were added for that.
So the average stay was hospital stay was around
7 to 10 days.
7 to 10 days. Very good. And like you did debridement in I think most of the cases. So was it repeated also? How many times the average?
Yes, sir. 12 cases underwent repeated surgical debridement. The range was 1 to 4. Like there were 2 patients who underwent 4 times surgical debridement, but on an average it was like once only.
And was general anesthesia required in these, or
The 8 patients were pediatric age group, and those were debrided under general anesthesia, and rest of them, because it's a painless condition most of the time, so in adults we debrided under without any anesthesia.
good?
Thank you. So now we invite next Mukesh Kumar Patil. Mukesh, sorry for wrong speaking. नहीं, मुकेश प्रकाश पाटिल है ना?
Yes.
टॉपिक बोल दो उसका.
So, good morning, everyone.
LASIK
I will be
enhancement
talking about LASIK enhancement after primary myopic LASIK. We do not have any financial interest. So, we aim to evaluate refractive and visual outcomes as well as complication in patient who underwent LASIK enhancement after primary myopic LASIK. It was non-comparative retrospective study of LASIK enhancement procedure done at AHI Hospital between March 2017 to March 2022. The post-myopic LASIK patient with the residual refractive error and myopic regression were considered for enhancement. The patient with a minimum follow-up period of 1 year after LASIK enhancement were included. So overall, 58 eyes of 46 patients were included. 1 eye in 34 patients and both eyes in 12 patients were enhanced. The flap relief technique was followed for all enhancement procedure. All patients were treated with the Alcon Wavelight EX500 excimer laser platform. The SPSS software was used for statistical analysis. The pre-enhancement inclusion criteria was residual or regress refractive error, uncorrected visual acuity of 20/40, patient dissatisfied with outcome, and at least 6 months has passed after primary LASIK procedure. The exclusion criteria were corneal ectasia, irregular corneal topography, post-enhancement residual bed thickness of less than 300 micron, irregular LASIK flap, fibrous flap margins, corneal scar, lenticular changes, and severe dry eye. Now moving on to the surgical technique. The flap margin was identified and marked on the slit lamp with the help of needle. A bent 26 gauge needle was used to separate flap over few millimeters. A blunt LASIK flap elevator was used to dissect flap carefully. The flap was dissected fully till the hinge and the flap is retracted. The residual or regress refractive error was enhanced. The flap was repositioned, the interface wash was done, and the procedure was concluded. Now coming to the results, in 70% of the cases, male underwent enhancement. In 42% of the cases, the both eyes were retreated. The average duration between the primary LASIK procedure and the enhancement was 26.96 months with the standard deviation of 18. Before the primary LASIK procedure, the mean refractive error was minus 4.39 diopter with the standard deviation of 1.9. Before the enhancement procedure, the mean refractive error was minus 1.31 diopter with the standard deviation of 0.44. And after the enhancement, at the end of 1 year, the post-enhancement mean refractive error was minus 0.03 with the standard deviation of 0.55. And there was statistically significant difference between the pre and the post-enhancement spherical equivalent values. Now coming to the visual outcomes, at the end of 1 year, the 88% of the eyes were within a range of 0.5 diopter sphere. 97% of the eyes were within a range of 1 diopter sphere. At the end of 1 year, 80% of the eyes had uncorrected visual acuity of 20/20, and none of the eyes has lost best corrected visual acuity of more than 1 line. Coming to the complication at the end of 1 year, the 7% of the eyes developed grade 1 epithelial ingrowth, and the 2% of the eyes had flap-related complication. Both of were managed conservatively. The studies in the literature also shown that the LASIK enhancement after careful evaluation and customized treatment, they give satisfactory result. So to conclude, our study suggests that the LASIK retreatment with the flap lift technique is a safe, effective and predictable procedure for the management of post-myopic LASIK residual or regress refractive error. Thank you.
Thank you. How you differentiated between the regression and progressive myopia?
Sir, with progressive myopia, mainly we have to see on the any axial length changes.
So it was not recorded pre-op.
Sir, axial length, I have excluded in the exclusion criteria.
No, patient got treated suppose 2 years ago.
Yes, sir.
That time axial length was not done.
Yes, sir. Before the enhancement also and before the primary LASIK procedure also, the axial length was done.
For all patients,
Yes, sir. For all.
preoperatively
Yes, sir. Yes, sir.
on
Also.
primary patients
Yes,
also.
sir. And
Okay.
even before enhancement, those who are having stable refractive error, we have included them for the enhancement procedure.
Okay. What was the cutoff for minimum to consider for enhancement?
Sir, if we talk about refractive error, it was minimum was minus 0.75 diopter sphere, and if the vision is less than 20/40.
And all patients were improving with the refractive correction to 6.6 preoperatively?
Sir, before enhancement you are talking?
Yeah.
If the before enhancement, sir, there were two main criteria. If the vision is less than 20/40 and the patient is satisfied with the result, and there is a residual refractive error of at least 0.5 or 0.75.
No, but there can be 0.5 error because of decentration. Patient is not happy or reading 6.6. So that was excluded or not excluded.
Sir, we
Or
have
you have
checked-
done customized treatment to enlarge the optical zone or to make it center. Topo guided treatment was done for any patient or not, or
Sir,
it was only a
all-
pure refractive correction.
They were wavefront optimized only, sir, but we do go through the topography patterns and OCT patterns to see the any decenter ablation. The
So they are
zone-
included in the study or not? That is what I'm asking. They are included or excluded?
Sir, no, they were excluded.
They have been excluded.
Yes,
So it
yes,
was pure refractive correction.
Yes, sir. Yes, sir.
Okay. So the take home message is that the flaps can be relifted at any point of time, even 10-20 years also you can relift the flap in LASIK patients. The techniques can vary. I prefer not to use 26 gauge needle because then the chances of epithelial ingrowth will increase slightly. Bent needle is not good. You can use a spatula and keep the cornea wet when you are maneuvering the flap.
Okay, sir.
Good presentation.
Thank you.
Yeah.
Yes, sir.
Like surface treatment was not done in any of the
Yes,
patient.
sir.
Huh?
Sir, those group of patients were excluded in this study. The patient with the irregular flap or fibrous flap margin, we are already excluded, sir.
No, he is asking that considering relifting or doing surface ablation on the same patient.
Sir, literature has shown that surface ablation has more chances of haze and unpredictable outcomes. So flap relift is more predictable.
Okay, thank you.
So we invite Dr. Nidhi Pahadia, and she will be speaking on.
Unraveling the spectrum of uveitis, insights from Western India. Good morning, everyone, respected judges and all my colleagues. I'm here to present you the presentation, Unraveling the Spectrum of Uveitis, Insights from Western India. As we all know, uveitis is a sight-threatening disease, which is a very important cause of ocular morbidity. In developed country, almost 5 to 20% of cases, it constitutes of 5 to 20% cases of legal blindness, while in a developing country like India, 25% of blindness is caused by uveitis. Correct diagnosis is very important and often challenging, despite evolution of the bestest diagnostic techniques, as etiology remains elusive in a significant number of patients. So the objective of the study was to assess the prevalence of uveitis in patients of all age group, assess the potential risk factors and causes, and assess clinical features and manifestations. The method, it was a retrospective observational hospital-based study, included all patients diagnosed with uveitis. Institutional ethic committee clearance was obtained and consent was taken from all participants. All the patients who were diagnosed with uveitis in our hospital were included visiting in January to September, and the terminology and classification was used by SAN, that is Standardization of Uveitis Nomenclature. The exclusion criteria included all patients who refusal for consent and did not undergo the said investigations. The workup: detailed clinical history, complete ophthalmological examination, physical examination, laboratory test, ancillary test was performed. The ocular examination included external examination of ocular adnexa, slit lamp evaluation, fundus evaluation, indirect ophthalmoscopy, OCT, FFA, autofluorescence, and ancillary tests were used as and when needed, like USG and visual field. The laboratory was CBC, urine analysis, Montooks, TPHA, serum ACE. The approach was basically tailored according to the patient. They needed serum ACE level, viral markers, toxoplasmosis, HLA typing, HRCT, according to the patient. So the test for non-infectious was ANA profile, rheumatoid factor, HLA typing. The patients were referred to rheumatologist, pulmonary medicine as and when they needed. So the total patients included in our study were 137. The included finally, after excluding, we had 106 patients. What we noticed was that 69% of the patients had unilateral presentation in one eye, while 37, almost 34% patients of the had bilateral presentation. And what was more commonly seen that the posterior panuveitis had bilateral presentation, while anterior uveitis patient had unilateral presentation. The male in our study was 61% and the female was 38.6%. The male is to female ratio was 1.5 is to 1. That means male has a more preponderance, and the mean age of patients was 43 years old. But the range, most of the patients belong to 18 to 60 years of the patient. So coming to etiology of anterior uveitis. So most of the patients were idiopathic, but HLA-B27 constitute the maximum of the anterior uveitis, almost 30%. Now this is surprising in comparison to other studies. Our viral uveitis, anterior uveitis was very high. It was 14%, which is not normally seen. This can be because we at a tertiary care eye institute like ours, not all the patients, we don't get even our anterior uveitis presentation, 32% is less than what is generally known. Probably because of the tertiary care institute, not all patients come to us directly. The presentation of Fuchs was 8% and GIA was 5%. Now, intermediate uveitis is present with dense vitritis and snowballs and snow banking. They were also common, and most of them, we treated them with steroids, but we did not know the final diagnosis as a vitreous tab was not taken. In posterior uveitis, in our study, we came across 30% of retinitis patient, 43% of choroiditis, and 27 of vasculitis. Now, it's not that easy because retinitis and choroiditis, they are two adjacent structures. So, at times, it's retinochoroiditis or chorioretinitis. So, to say it 1% is very difficult. Still, patients like this, she was a young female, 23 years old. She came to us with a solitary lesion. So, this looks like tuberculoma. In the OCT, you can see a contact sign was present, and she had a perilesional ring sign on FFA. Similarly, choroiditis, it can be unifocal or multifocal, and what you see is not what it is. At times, in autofluorescence, when you see in the picture left side, there are only hardly you can see, but on the right side, you can see so many hyperfluorescence, signifying that it is iceberg, tip of iceberg, what you are seeing. So, like this patient, he came to us. He was a 34-year-old male who came to us, and we diagnosed him with serpiginous choroiditis. He was started on steroid. Despite on steroid, he is progressing. If you can see in the last picture, the lesion, so it is increasing. Despite he is on prednisolone, on Azuran, on Septran, all these medications still. So you have to keep a very close check, and you have to keep consultation with rheumatologist, pulmonary medicine, so as to know that you are on the right track. So, coming on to the final panuveitis, in our patient, probably we did not take vitreous tab from all patients. Only few which we were seeing probable confusion. We only take vitreous tab. Not vitreous tab was not taken from all patients. So, probably tuberculosis in 5 patients, fungal was in 1, viral in 2, toxoplasmosis 1, and idiopathic was 7. Now, non-infectious Behçet's, it is very surprising for us to come across 5 Behçet's patients in Rajasthan belt, because of all studies I came across, nobody has recorded 5. So this is surprising that in Rajasthan we are having so high cases of Behçet's and sarcoidosis VKH. Now, the important thing is we have to take a proper clinical detailed history. Behçet's can only be diagnosed if you have taken a proper history. So, conclude. VKH patients, this is the same patient that I was saying. This you can see stippling, and this subretinal and the bacillary layer detachment on OCT. So the steroids.
Sum up. You have to stop. No, in
Yes,
free paper we do not allow even summing up.
Yes, sir. Steroid induced.
You have to stop it here
Okay,
only.
sir.
So, all right. In your cases, did you encounter any relapse also or recurrent cases?
Yes, sir. Many. Not one, sir. Lot of patients, sir.
So did you included data of that also, that how many of them they had
Sir,
relapse in?
it is ongoing study, so we are including, but this was not a part of this study. This I just wanted to present the prevalence, so I've not included in the study. But
Okay.
yes, sir, we are keeping a record of how many patients are relapsing.
Okay. And in Behcet's, like, how did you diagnose the cases of Behcet's?
So basically, Behcet's is a pan-uveitis. It will have anterior, intermediate, posterior at all level. But the Behcet's is mainly diagnosed based on history. He will have genital lesions. He will have oral ulcers, and the patient will give you history. And sir, obviously, ophthalmologist alone cannot diagnose. HLA-B51 typing is done, and rheumatopenia is taken. So this is not only ophthalmologist per se domain, and we do obvious imaging. So, sir, it's a
No, actually, to diagnose Behcet's, there are set guidelines by American Rheumatologist Associations, major criteria and minor criteria.
yes, sir. Yes, sir. Oral ulcers, genital ulcers.
So
These are
you
five
have
history.
to
ANA, sir.
diagnose them based on those specific criteria. One major, two minor, two
Yes, sir.
major,
Yes, sir.
one
Yes, sir.
minor.
Yes, sir.
So you'll have to speak out there.
So you have retrieved this retrospective study, and you are saying it is an ongoing study. So you want to say that all patients who will be included now onwards will be having a retrospective nature, or you will be doing something for including the new patients and have a better documentation and diagnosis.
Sir, the
Because
old patients
what we
will
are
be.
suspecting is that the data was taken from OPD prescriptions,
Yes,
they
sir.
were not admitted.
No, sir. No patient was.
So sometimes the patient may be seen by one consultant, other consultant, or residents even.
Sir,
So the
there is
reliability of
only,
finding will be
sir,
a,
only two consultants see UVA. All patients, and nobody, no matter who sees, they will refer them to UVA clinic. So the final conclusion and final treatment is under only two consultants.
so have you considered wherever there is something like a query written, uveitis, query fungal, query viral?
Yes, sir. Yes, sir. Because sir,
So how you considered them into query or confirm?
sir, we are saying query because we only confirm the diagnosis only of clinical features what we are seeing. Like sir, in patients of VKH, we don't need to confirm them. We can see bacillary layer detachment. We can see pinpoint stippling on FFA. So we have not confirmed, but sir, on clinical features, we are sure that this is VKH. So and similarly, sir, a case of fungal we came across. Initially, it was tubercular, but sir, the presentation, the clinical features, and it is improved on antifungal treatment. So because of that, we concluded that yes, this is that.
So my suggestion is that now you should form some protocol system and format by which you can actually come out with the actual data, and then we can have an insight that this is the prevalence in this part of
Yes,
the.
sir. Yes, sir.
Okay, thank you.
Okay, sir. Thank you.
So next.
Next presentation is done by Dr. Pooja. Is she here? Yeah.
Next week, Lalo.
Yes. And subsequent presentation would be done by Dr. Poonam Jain. So she should be ready here, okay? After her, yeah.
Good morning, everyone. I am going to present the comparison of the accuracy of the 6 different newer generation IOL power calculation formula and their predicted refractive error with the actual post-operative refractive correction. The following are my headings. The aim is the same as that of the title. The introduction, an important objective of the cataract surgery in the today's era is the minimization of the refractive error, and its prerequisite is the appropriate IOL power calculation formula. The IOL Master 700 is an innovative optical biometer, and it is based on the swept source optical coherence tomography. The material and the method. The STD type is the retrospective interventional STD. The STD population is the 78 patients who underwent phacoemulsification cataract surgery, and the IOL IHANS ICB00 model implantation at our hospital between the 21 April 2023 to 21 September 2023. The inclusion criteria, the patient who underwent cataract surgery and implanted with the only IHANS ICB00 model, which is an advanced monofocal IOL, and the exclusion criteria is the when the optical biometry was not possible, example the hypermature cataract, any ocular disease that could affect the refractive status after the surgery, the previous corneal surgeries, intra and the post-operative complications. The IOL Master 700 data were collected of the patients who had the phacoemulsification with the implantation of the IHANS IOL performed by a single surgeon using the SRKT, Hoffer Q, Barrett Universal 2, Holade 2, IOL power and the respective predictive post-operative refractive error were calculated automatically by the software. The IOL power and the respective predicted post-operative refractive error were calculated manually using the freely available online calculator for the EVO 2.0 and the Pearl DGS method. All the data were tabulated in the Excel and the SPSS software version 20.0 was used for the statistical analysis. The prediction made by each formula were optimized by adjusting their constant to give an arithmetic prediction error of 0 in the average case. The mean prediction error, median absolute error, and the mean absolute error and the percentage of the I with the prediction error within plus minus 0.25, plus minus 0.50, and plus minus 0.75 were calculated. The prediction error in the postoperative refraction is defined as the actual postoperative refractive error minus predicted error by each formulas. So the Barrett's Universal 2 formula is based on the theoretical model I, and it retains the positive correlation of the axial length and the keratometry to the anterior chamber depth. Similarly, the Holade formula is also is a theoretical based on the theoretical model I, and it is based on the Holade 1 formula, and it uses the 7 parameters for predicting the surgeon's factors. The SRKT formula is a theoretical approach to the IOL power calculation under the SRK umbrella of the empirical formula using the existing A constant and the optimization method. The Hoffer Q relies on the personalized anterior chamber depth, axial length, on the corneal curvature. The emetropia verifying optical formula, or the EVO 2.0, is an unpublished formula, and it is based on the theory of the emetropinization and generates an emetropia factor for each eye. The Pearl DGS method is based on the artificial intelligence and the optical calculation, and it is mainly a machine learning model, and it is dependent on the input data. The results, the demographic variables, the male is to female ratio in RS3 was the 34:45. The mean age was 63.75 plus minus 5.26 standard deviation, and the right eye is to left eye ratio was 35:44. The range of the power of the IOL implanted into the patients were the patient with the 10 to 15 diopter was 6 patient, the patient with 15 to 20 diopter were 25 patient, the patient with 20 to 25 diopter were the 40, and the patient with 25 to 35 diopter were 7. The normality of the data distribution was assessed, revealed a non-Gaussian distribution of both the arithmetic and the absolute prediction error. The difference among the median absolute error of all the formula was statistically significant. Lowest value were achieved with the Barrett's Universal 2 and the SRKT. A percentage ranging from the 80 to 88.5% of the eye showed a prediction error within a plus minus 0.50 diopter, and all formulas achieve more than 50% of the eyes with a prediction error within plus minus 0.25. These are the data in the tabulated form. Discussion: according to our analysis, the good refractive outcome can be achieved with all the formulas taken. Around 50% of eyes were within the prediction error of plus minus 0.25. And around 80% of the eyes were within prediction error of plus minus 0.50. The limitation of this study was the prediction made by each formula were optimized by adjusting the A constant to give an arithmetic prediction error of 0 in the average cases, and the IHANS ICB 00 was not in the database of the authors of the EVO 2.0 formula. These are my references. Thank you.
Nice study. So, which formula did you use in your cases to implant the IOL out of these 6 which you are enumerating here?
Barrett's Universal 2.
Pardon?
Barrett's Universal 2.
Barrett's Universal Group was the one which you used. And you have analyzed data according to the IOL power which was used. So, was there any difference in the prediction of higher power and the lower power IOLs as the literature suggests? And the standard means 15 to 25 diopter IOL power the prediction value was higher, or it was like I could not take out it from your
Sir,
data?
actually, we didn't took the two extreme value, means we have not taken the too myopic patient and too much hypermetropic patient. So they were the intermediate eyes. So
But
data
that's
were
what I'm
not.
asking. No, you have
Yes,
taken 4 groups,
yes,
10 to
sir.
15, 15 to 20, 20. So what I'm saying is,
It was
asking
not
is, it,
significantly
like
different.
all of them,
Yes,
they had good prediction
yes.
value, and all the formulas were equal. Okay. So I think one more parameter which could have been included was the suggested IOL value difference between all these 6 formula. Like suppose a patient is requiring 21 diopter on holiday 2. Now, like rest all 5 formulas, are they also suggesting 21, or some of them are suggesting 21.5 or 20.5? So that variation and the final the result which you obtained and correlation of your result with the suggested IOL power of these formula. So that would have been a little more contributory towards having more insight. Otherwise, it's a nice study.
Thank you, sir.
So next we invite Dr. Poonam Jain, and she is going to share data on the multi-layered inverted ILM flap versus standard peeling of large macular holes, a comparative study. Over to Dr. Poonam.
Good morning, respected teachers and colleagues. Today I'm presenting a prospective study comparing the multi-layered inverted ILM flap technique with standard ILM peeling for large macular holes. We have no financial disclosures to make. ILM peeling assisted pars plana vitrectomy is a safe and reliable surgical technique for macular hole with excellent closure rate. In difficult situations like large macular holes, the surgical outcomes are usually poor. Extensive areas of ILM denudation is done for better outcome, resulting in progressive dissociation of optic nerve fiber layer, loss of photoreceptor layers, RPE defects, etc. So suboptimal visual recovery and frequent need of resurgeries is there. To overcome these problems, Michalishka et al. Described inverted ILM membrane flap technique. This novel technique was found to result in better anatomical and visual outcomes compared to standard macular hole surgery. Several reports have compared both techniques, debating to conclude the preferred ones. Various ILM flap-related problems, including misplaced flaps, loss of flap in the cutter probe, can occur with original inverted ILM flap technique. So the aims and objectives of the study to evaluate the outcome of vitrectomy with multi-layered inverted ILM membrane flap technique versus vitrectomy with ILM peeling, standard macular hole surgery for large macular holes with diameter more than 600 microns in terms of anatomical closure and visual acuity, and to describe a modified approach of inverted ILM flap in macular hole surgery which helps to minimize the flap-related complications. It's a hospital-based prospective randomized interventional study conducted during 3 calendar years among patients referred to a tertiary care eye center. A total of 150 eyes were included in the study after consent. Cases were randomized, and vitrectomy with standard ILM peeling, group A, and vitrectomy with multi-layered inverted ILM technique, group B. The patients were treatment naive. Idiopathic full thickness macular holes with minimum base diameter of more than 600 microns were included. Patients with other ocular comorbidities were excluded. A complete ocular examination, including OCT, were done, and all surgeries were performed by a single surgeon in this study. For the surgical technique, in both groups, after pars plana vitrectomy, a PVD induction, BVG dye was injected. In group A, ILM was grasped and peeled in a circumferential pattern for about 2 disc diameters around the macular hole using ILM peeling forceps. Whereas in group B, a small bubble of PFCL was injected in the posterior pole. Multi-layered flaps were fashioned towards macular hole edge and rolled up inside the edge with ILM forceps. The PFCL bubble was slowly aspirated. Fluid exchange was done. The ILM clump formed at the center did not dislodge after PFCL aspiration, and 20% SF6 gas was used as tamponade. Post-op phase down, so there's a short video. So the BVD is induced, triamcinolone was injected, BBG is injected to stain the ILM. PFCL bubble is injected. The ILM, multiple ILM flaps are being made under PFCL. and they stay there. Their fluid exchange done, and the PFCL is aspirated. So follow-up was done at first week, 1 month, 3 months, 6 months, and 12 months. The main outcomes measured on OCT were anatomical closure and type of anatomical closure, whether type 1 or type 2. At the end of study, data was collected, documented, analysis was done. For pre-op analysis, the age, duration of macular hole, the diameters, and the pre-op visual acuity were comparable in both groups. They were not statistically significant. Whereas when we compared the result, for anatomical closure, the patients in group B with vitrectomy with inverted ILM flap, 100% hole closure was found, and whereas in group A, 93.3% hole closure was found. And the important thing was the 93% hole closure in group B was type 1, which is the perfect hole closure. And whereas in it was typed, there was no case where closure was not seen in group B, whereas there were 5 cases, 6.67% in group A, where closure was not seen. The visual acuity also was statistically significant. The gain in visual acuity at the end of 12 months in group B was better in group B. These are the cases, the 3 cases shown where there are large diameter holes, and they're all being closed with type 1 closure. So ILM peeling relieves the tractional forces responsible for causing the hole, as well as triggers reparative gliosis by injuring the Muller cells. Large macular holes have a propensity to remain open with standard ILM peeling. Thus the need for plug-in supplements for large holes. There are few inherent challenges present in conventional inverted ILM technique, particularly while using non-valve trocars secondary to fluid turbulence. The ILM under PFCL becomes thread-like in texture, does not float freely under the high surface tension of PFCL. It aids in easy repositioning and maneuvering of the flap. The stability of the flap is excellent after PFCL aspiration. No case of flap loss or flap dislocation was noted under PFCL in the present series. No need to trim the multiple flaps with the cutter, as the ILM under PFCL folds back on itself inside the hole. There was ample scaffold inside the macular hole, high probability to achieve a type 1 closure. To conclude, vitrectomy with multi-layered inverted ILM flap technique had a significantly better success rate, anatomical closure, and better visual outcome than the standard macular hole surgery. The multi-layered internal inverted ILM flap technique under PFCL provides a smooth and gap-free natural scaffold for migration of glial cells and photoreceptors towards the fovea. The multi-layered ILM technique under PFCL is a safe and easily reproducible technique and offers distinct advantage over all currently described ILM peeling technique in terms of flap-related complications. This procedure, okay. Thank you.
Nice study, Poonam. So, is there any disadvantage of ILM peeling and this the newer technique?
Standard and multi-layer.
Standard and multi-layer closure.
The inverted flap techniques is way better than the standard technique where only ILM peeling was done. But with flap techniques, this technique is better because which we have seen with the kind of closure and kind of visual acuity we have gained. So loss of flaps and flap dislocation is common with normal ILM peeling with inverted flaps. So when we do multi-layered flaps with PFCL bubble, the loss of flap and we don't need to trim the flaps, and the loss of flap is rare.
Both the groups you have done the randomization or by selection that
No,
this
sir.
is a whole big or
No,
this
sir,
is
randomized.
randomized. So what were the criteria taken for randomization? Means the whole size or
No, sir,
the duration or the height
No, sir,
or age?
No, both the groups, there was no statistically significant difference. So they were randomly divided into groups.
Statistical method.
Yes, sir, statistical.
Okay. Thank you.
Thank you.
So we invite the next speaker, Dr. Pratik Jain, to share his study on topical mitomycin C as a monotherapy for OSSN, a case series. And meanwhile, next, Dr. Rasik Priya Sandhu, if she is here, be ready on the other side. Yeah.
Good morning, one and all. I would like to present my topic, a case series, the role of mitomycin C as monotherapy in ocular surface squamous neoplasia. I am going to touch the topic under following subheadings. What is OSSN? OSSN is a umbrella term that describes changes from dysplasia, CIN, squamous carcinoma of the epithelium involving cornea, limbus, and conjunctiva. Being common in 6th and 7th decade, it is the third most common ocular surface tumor after melanoma and lymphoma. Among the various etiological factors, exposure to UV radiation is the most common one. It causes DNA damage, and cells with the damaged DNA proliferate and leads to development of OSSN. Based on the morphology, OSSN can be classified as nodular, diffuse, papilliform, leukoplakic, and gelatinous variety, which is the most common one. Among the various treatment options available, surgical excision is the gold standard one. Other options include cryotherapy, radiotherapy, topical immunotherapy, which include interferon alpha-2b, topical chemotherapy with mitomycin C. Why I chose mitomycin C over interferon alpha-2b? Simply because it is readily available, relatively cheaper, doesn't require cold storage, has lesser duration of therapy, and it is equally promising. Indications of using mitomycin C eye drops are as a primary treatment in patients who don't want surgery, as neoadjuvant treatment to reduce the size of the tumor before the surgery, as adjuvant treatment in EDGE and BAS positive tumors after surgery, and in refractory tumors. How does mitomycin C works? It binds to DNA during the cell cycle and causes irreversible cross-linking of the DNA, which inhibits the RNA and protein synthesis and causes tumor regression subsequently. How to prepare mitomycin C 0.04% eye drop? For that, we have to add 5 ml of distilled water in 2 milligram of commercially available mitomycin C injection vial, and to get 0.02%, we have to add 10 ml of distilled water. I use 3 cycles of topical mitomycin C. Each cycle consists of 1 week of on cycle followed by 1 week of off cycle. Among the numerous various side effects, our patient experienced only mild side effects like hyperemia and lacrimation, which were taken care of by addition of topical lubricants and reduction of mitomycin C concentration to 0.02%. The diagnosis of OSSN is basically based on clinical morphological features, which include presence of sessile fleshy mass in the interpalpebral region with epicenter at the limbus, presence of rose Bengal stain, feeder vessels, and keratinization all together constitute most sensitive and specific hallmark for the OSSN. Now I'm going to show multiple cases which were recorded, which are put on 0.04% mitomycin C for 3 cycles in the following slides. The case 1, 56-year-old male presented with papilliform OSSN and showed complete regression at the end of 3 cycles. Here comes the after story. Patient at the start was PL positive. Post mitomycin C therapy, he got BCV of 3/60, and post cataract surgery, the BCV improved to 6/9. The case 2, 68-year-old male patient with leukoplakic OSSN showed complete regression after 3 cycles of therapy. We can see in the diagram how the tumor is getting downsized in the subsequent cycles. Case 3, 30-year-old female with mixed OSSN put on 0.04% mitomycin C, showed persistent hyperemia. The dose was reduced to 0.02% and showed beautiful response after 3 cycles. Case 4 and case 5 was 55-year-old male with papilliform OSSN and leukoplakic OSSN relatively showed beautiful response after 3 cycles of mitomycin C. Case 6, 35-year-old male patient with HIV positive status, one-eyed patient, was put on 0.02% mitomycin C and showed complete regression after 3 cycles. Case 7, a mixed OSSN with dirty-looking pigmentation, put on 0.04% mitomycin C and showed reduction in the size, incomplete regression, and I advised him for surgical excision. So to conclude, I would like to stress upon the fact that complete regression of tumor with 0.04% of mitomycin C in 3 cycles are good enough and have minimal side effects. No recurrence was reported in the follow-up of 12 months in all patients and in follow-up of 2 years in 3 patients. So, mitomycin C can be considered as topical monotherapy in OSSN for mentioned indication with proven efficacy. Thank you.
Nice presentation, Dr. Pratik. My question is that how did you diagnose OSSN?
So, OSSN was basically diagnosed by the clinical morphological features like presence of the Rosebanger staining.
So that's not the foolproof method of diagnosing it. You need to have histopathological diagnosis before starting MMC or any other modality. That's the gold standard guideline actually. One. Secondly, you did not have any case with side effects of mitomycin?
So few patients showed redness and they were intolerant to mitomycin C at the start, but by reducing the dose to 0.02%, they tolerated it well.
None of them had serious side effects like stem cell because that's the advantage of interferon alpha over mitomycin. All right.
And how you applied this mitomycin?
Sir, it was applied by topical drops.
No, means 4 times a day
4
you are
times a
giving
day.
drops.
For 7 days and followed
any
by
instructions given to the patient that what care they should take?
they have to be like strictly compliant and put drops regularly and have to come for the follow-up.
Okay. Any instructions given that if you develop this or that, you should come early or?
Yeah. It was
what was the instruction?
Sorry, sir?
What was the instructions given to them, or they were being just asked to come after 7 days every time?
No, they were asked if they feel any kind of discomfort, they should report early.
Okay. Any lubricating drops or something else was used along with this?
Sorry, sir?
Any lubricating drops were also used along with this?
Yeah, it was given in the off cycles. Lubricating drops like CMC was given in the off cycles.
Okay, thank you. So, Dr. Rasik Priya is the next speaker, and she is going to speak long-term outcomes following Sioni ring bag fixation in the bag IOL implantation retrospective observational study.
Good morning, everyone. The topic of my study is long-term outcomes of Sioni ring bag fixation and in the bag IOL implantation. I have no financial disclosures to make. We all know that the loss of substantial zonular support leads to challenges for successful lens removal and subsequent implantation of an intraocular lens. Cataract surgeons now have an armamentarium of options in their to deal with for IOL implantation. One of the techniques commonly used is performing a lensectomy with a vitrectomy and anchoring the IOL either to the scleral wall or fixating it to the iris. However, when we use this technique, we are willingly sacrificing the capsular bag, and therefore there is a loss of compartmentalization between the anterior and the posterior segments of the eye. When we use Sioni rings, we preserve the capsular bag, and this enables us to place the IOL in its most anatomical position, which is the capsular bag. Also, we do not disturb the anterior phase as no vitrectomy is performed, and there are possibly no vitrectomy-related complications in these eyes. This is a Miyake apple view from the posterior segment of the eye, which shows a very well-centered capsular bag complex with the use of an MCTR. There have been many concerns about the about the performance of these eyes in the long term, and one is about the biodegradability of the suture material. By now, it is well established that 10-0 suture undergoes biodegradation, and as a result, most people have switched over to using a 9-0 Prolene suture, and also there is some use of an upcoming Gore-Tex suture. These are representative pictures from our study showing the use of both single and double eyelet Sioni rings. Many groups have been involved in the study of the performance of these eyes in the long term, including our own group. However, a constraint of the previous studies has been that they have been limited to a period of about, say, a maximum of 5 years post-operatively. To the best of our knowledge, there are no reports in literature with a follow-up of more than 9 years for these eyes. This is a retrospective observational case series, and we included all eyes which underwent an MCTR fixation using a 9-0 Prolene suture and had an in-the-bag implantation of a single-piece hydrophobic acrylic IOL. Subluxations of any etiology were included, and only those cases were analyzed in which at least 5 years of post-operative data was available. So looking at the results, what did we see? In terms of demographics, our cohort included 41 eyes of 31 patients. and the mean age at surgeries was close to 20 years, ranging from a very wide range of 4 to 50 years. Also, it is very interesting to note that all children that is below 15 years accounted for almost 60% of the eyes. In terms of preoperative diagnosis, not surprisingly, Marfan's was the most common diagnosis, counting for 40% patients, followed by trauma. And in 4 out of 10 patients, we could not ascertain any underlying etiology. The mean follow-up in our study was 9.9 years, ranging from a minimum of 5 years to 20 years. Looking at the devices used, a single eyelet was used in 36 eyes, which is close to 90% eyes. In 1 eye, a double eyelet was used, and in 4 eyes, we use MS segments in conjunction. Outcome measures included CDV at final follow-up and the incidence of postoperative complications. The CDV at final follow-up was better than 612 in almost 75% eyes, and in only about 10% eyes of which the final follow-up CDV was less than 660. Looking at the postoperative complications, not surprisingly, PCO was the most common complication seen in 42% eyes. A decentration which required surgery was seen in 17% eyes, and retinal detachment was seen in 10% eyes. All the eyes which required treatment underwent an NDR capsulotomy, and the mean time at which PCO was noted was 1.4 years post-surgery. 7 eyes required a resurgery for decentration, and in 4 eyes we could refixate the original back complex using a Gore-Tex suture, but in 3 eyes a refixation was not possible. Therefore, an IOL explant was performed with an exchange. This is very important for us to note because we have to counsel all our patients preoperatively that usually these eyes are sick eyes and there might be a need for a subsequent surgery for these patients. The mean time of primary surgery to the resurgery was about 8.8 years. This is a 15 years follow-up patient of a pediatric patient. Please note that there is a beautiful YAG capsulotomy opening. However, there is a total biodegradation of the suture material, yet the IOL back complex is death stable. RD was seen in almost 10% eyes. 3 out of these 4 eyes had a preoperative diagnosis of Marfan's, and 3 out of these 4 eyes are pediatric eyes. It is very important to follow up these patients because most of them are young patients who have a very long lifespan ahead. So subsequent retinal evaluation is warranted to rule out any subsequent RD in these eyes. In conclusion, I would like to say, yes, this is a very skill-dependent procedure, but this should not dishearten us because the final CDVA is very heartening, as almost 3/4 of the patients had a vision of better than 612. PCO was the most common complication in 41% patients, and 17% patients needed a resurgery for a decentered IOL. Also, since biodegradability of 90 is also known, there is an upcoming role of the Gore-Tex suture which needs to be evaluated. In addition, we also do not know about the long-term outcomes of sutured and sutureless scleral fixation, and that is another thing that needs to be evaluated to see the efficacy of these things. Thank you.
Thank you, Dr. Rasipriya. It was a very good study. I have a few questions. That you use the Sioni ring and you have already spoken about the suture material. Since the study started in what time? I missed some slides.
So, sir, this is a study in which we've included a minimum of 5-year follow-up and a maximum, the longest follow-up is 20 years.
Okay. So, the sutures used in initial phase like 20 years ago was what was the suture?
So, we use 90 Prolene.
Okay, that time it was not a trend to use 90. Now it is a trend to use 90. As far as I remember, it was 10-0 we used to do, but gradually we shifted to 90. Okay, and now you are using Gore-Tex in all, or you are using the same suture 90?
So this study is completed. It was an observation study, so we didn't use Gore-Tex in this study. But however, there have been other studies at our center in which we have studied the performance of Gore-Tex, and I think that is a 1-year follow-up for that study.
Yeah. No, not a matter to answer, please. No, I know you are expert for this. It is just for the presentation person. Yeah. The second thing, we all know the Marfan's and other patients, they usually have retinal complications higher than the other patients. So, anything was considered as a prophylactic treatment for these patients in post-op period?
So, all the patients in our studies had a 6-monthly follow-up, and every evaluation was included a related fundus examination.
And this study was done at what place?
So, this was done at both the centers here and in Ahmedabad.
Okay. How many patients are from here and how many are from Ahmedabad?
Sir, I'll have to look that up, please.
Okay. Mukesh want to ask.
In your study, around 18% patients they require recentration. So, what kind of suture was used in those 18%?
So, sir, out of these 7 eyes and 4 eyes, we could refixate the original IOL back complex using a Gore-Tex suture.
No, the original suture was 9 or 10 or like you used.
The original suture was 9-0.
All right, and that also got dissolved in 8 years duration. That's something eye opener actually. What we believe is that 9-0 prolene at least should stay. 10-0 used to be dissolved by 8-10 years. All right, thank you. It's a nice study as a whole, very nice study. But only issue is that work is not done in Rajasthan. Then this. No, but this is. I am just informing
As a
the
guideline,
house. Yeah, it is the guideline for free paper that work has to be done under Rajasthan.
But it's a exemplary work done, and a long data is a big thing. And now I invite Dr. Sandeep Chaudhary, and next will be Dr. Shanti Priya. Is she here? Okay, so be ready on the other side. So Sandeep Chaudhary is going to share about ophthalmologic profile of patients with systemic sclerosis, a cross-sectional study in 200 eyes.
Good morning, everyone. So, the objective of our study was to evaluate the ophthalmic manifestation in patients with systemic sclerosis and its correlation with autoantibody profile. Systemic sclerosis is a connective tissue disease mostly affecting middle-aged adults and with a female preponderance. As we already know that the ophthalmic manifestation in systemic sclerosis, they often go unrecognized and they are multifactorial in origin, whereas where the generalized vasculopathy leads to posterior segment manifestation, while the fibrosis, it mostly affects the ocular adnexa and the anterior segment. In our study, it was a cross-sectional study of 100 consecutive patients and thus 200 eyes. So the systemic history, including age, gender, subtype of systemic sclerosis, disease duration, systemic involvement, autoantibody profile, and modified Rodnan skin score was taken. While in the ocular examination, lids and adnexa, anterior segment, posterior segment, tear film breakup time, Schirmer's, and choroidal thickness were measured. So swept source OCT was used for central subfoveal central choroidal thickness measurement, and OCT angiography was conducted in 8 eyes of 4 patients who had Raynaud's phenomena positive. So this was done in the winters just to see if the patients had the vascular had something similar to Raynaud's phenomena in the choroidal vasculature also. Now the results, most of our patients were middle-aged patients with female preponderance and diffuse subtype was more common. Average disease duration was about 6.9 years. While most patients had best corrected visual acuity and intraocular pressure within normal limits, but about 3/4 of our patients had ocular symptoms which ranged from burning sensation, itching, foreign body sensation, and floaters. Most patients in our cohort had never consulted an ophthalmologist, which is most likely due to more pressing systemic symptoms. Eyelid stiffening was noted in about 62 of 200 eyes, about 30% eyes, and which caused incomplete lid closure in some cases, and even to the extent that causing exposure keratopathy in one patient. Meibomian gland dysfunction was more common with diffuse subtype, and these patients had variable findings of eyelid thickening and telangiectasia, plugging of orifices. So meibomian gland dysfunction had an association with eyelid stiffening, while Schirmer's and tear film breakup time didn't have any association with eyelid stiffening. So choroidal thickness was increased in 34% patient and decreased in 7% patients. Modified Rodnan skin score was available for 84 patients and it was found to be associated significantly with eyelid stiffness. On immunological profile, the patients had a 97% positivity rate of ANA, and on further evaluation of antibody profile, we noted that the isolated presence of anti-SCL antibody was statistically significant for meibomian gland dysfunction and tear film breakup time of less than 10 seconds and eyelid stiffening. These are few isolated cases where patients had choroidal scarring. One patient had this angioid streaks, and one patient had pigmented epithelial detachment. But whether this was associated with systemic sclerosis or not still remains to be studied. To conclude, ocular manifestation and systemic sclerosis are heterogeneous, and this study highlights the need for an active, comprehensive ophthalmic evaluation in all the patients, especially the patients who are having diffuse subtype of systemic sclerosis, isolated positivity of isolated anti-SCL antibody, and a higher modified Rodnan skin score. So this study adds that meibomian gland dysfunction is common. Decreased tear film breakup time, meibomian gland dysfunction, and eyelid stiffness had a significant correlation with SCL antibody. And based on this data, further multicentric research can be planned for prevalence of eye involvement in systemic sclerosis. Thank you.
This study was done, the data is from which place?
This was my thesis in PGI Chandigarh, sir.
Okay.
Yes.
Usually what we do is that in competitive paper, the work need to be done in Rajasthan.
Okay, sir.
All right. And the other part was how many patients had ophthalmic findings?
3/4 of patients had ocular symptoms,
So,
which mostly included lids and head necks. About 3/4
so
patients.
what was where did you take the data? In your IOPD or in the
I had a co-guide, Dr. Shifali ma'am from rheumatology. She sent all the consecutive 100 patients of systemic
So
sclerosis.
basically, primary data are
Yes.
from immunology clinic.
Yes, sir. The modified Rodnan skin score and was taken from rheumatology files, while rest of the ocular examination was done by me.
Yeah, that's true. But the primary data was of immunology.
Yes, sir.
And then you like saw them for ophthalmic finding.
Yes, sir.
All right. Thank you.
So next, Shanti, you are ready? Yes. Okay. To study various outcomes of combined silicone oil removal and intraocular lens implantation. She is going to share the experience.
Good morning, everyone. Topic for today is to study the various outcomes of combined silicone oil removal and intraocular lens implantation. As we know that silicone oil tamponade is often used in the eyes with the complicated vitreoretinal pathologies, which is typically to be removed after 3 to 6 months. The presence of silicone oil accelerates the cataract progression in the patients. The aim and objectives of the study were to evaluate the various outcomes of the silicone oil removal and intraocular lens implantation in the terms of surgical outcomes, refractive outcomes, and the complication during the procedure. It was a study design of a retrospective cross-sectional study of duration 4 years, that was 2019 to 2023, and a sample size of 46 patients were included in the study. The inclusion and the exclusion criteria: the patient aged for 35 to 65 who underwent the vitreoretinal procedure at our hospital, and the patient who has pre-existing maculopathies, optic neuropathies, or the macular scars were excluded from the studies. All the patient who has gone the surgery during the period of 2019 to 2023, and analysis was done in the form of etiology, IOL power calculation, intraoperative complication, and post-surgery refractive outcomes. The results were collected and analyzed. Moving on to the results, the mean age of the patient who went the combined under surgery was 48 plus minus 12 years of age. The etiology in our study concluded to be rhegmatogenous retinal detachment in 32.4% of cases, tractional retinal detachment in 45.5% of cases, and VH in 22.1% of cases. The average preoperative axial length that was calculated came out to be 24.5 plus minus 3 millimeter. The average postoperative corneal curvature was 43.7 plus minus 3.1, and the IOL calculation, the formula used was SRKT in all the cases, and the mean IOL power was 23.5 diopter. Now the cataract status of the patient at the time of VR procedure and the time of combined surgery was compared. It was seen that 12 out of 46 patient has clear lens at the time of VR surgery and 0 patient at the time of combined procedure. NS1 to NS2 was present in 31 out of 46 patient, which gradually progressed to 43 out of 46 patient. In NS3 was in no patient has cataract of more than NS3 in the primary step of the surgery, and the combined procedure, the 3 patients out of 46 has the combined results. The cataract status of the two patients was unknown as the surgery was performed at some other hospital, and the average time between two procedures was 4 plus minus 2 months. The vitreoretinal surgery was performed by two doctors at our hospital, and the phacoemulsification was performed by the another two surgeons. Only one case has a complication of 3 kilocar zonular dehiscence that was managed with the help of CTR. Now, discussing the refractive outcome, it was seen that none of the patient has refractive vision more than 618 at the time of the procedure, and 32 out of 46 patients, that is 69.56%, has VCA better than 618 at the follow-up of 2 to 4 weeks. For the vision of 660 to 624, there were 7 patients pre-operatively and 11 post-operatively that has the BCVA of 660 to 624, and 39 patients has the vision less than 660 at the time of presentation of vitreoretinal surgery, and only 3 patients out of 46 has the post-operative VCVA less than 660. Now the refractive failure. We divided the refractive failure into 3 steps, that was myopia, hypermetropia and astigmatism. Myopia was considered to be when the residual error was more than minus 1.5 diopter, the hypermetropia more than plus 5 diopter, and the astigmatism that is more than 1.5 D cylinder. 2 out of 46 patients, that is 4.3%, was myopic with more refractive error minus 1.5 diopter, and 1 patient was seen to be hypermetropic with more than plus 0.5 diopter, and none of the patient has a residual astigmatism of more than minus 1.5 diopter. Also, there was 3 out of 46 patients who show the post-operative IOP rise. Early PCO formation was seen in 7 out of 46 eyes, and there was need of resurgery in 2 out of 46 eyes. Thank you.
Well, thank you. I think it is a well-established fact now, combined surgery. Only concern is regarding IOL power calculation 1, which you have got a very nice correlation, like only 2 patients had myopic residual error and all. And the other thing, added point I think, is that generally a Tenno suture is placed at the main wound when the combined surgery is done along with SOR. So was it applied in your cases?
So in our study, around 12 cases had one suture was applied on that.
So that generally may create some astigmatism, but you have said no astigmatism was created in any of your patients. So that's something.
So what was the aim? Because this is a common procedure to do combined. So what you wanted to study actually?
Sir,
That should we stop doing combined?
No, sir.
Or
In our study, we used SRKT formula irrespective of the axial length of the patient. So one
so
is the factor
SRKT is considered across all axial length. It is a routine. No. And all were optical biometry done? Or
so IOL master of 500 was done.
so it was done in all?
Yes, sir.
Okay. There was no issue like this that some patient could not be assessed on IL master 500?
No, sir. All the
Okay.
patients.
So they were relatively early cataract kind of situations.
Yes, sir. NS1 to NS2. After 4
Okay.
months.
Okay. Okay.
Thank you.
Thank you. So now I invite Dr. Sonal Agarwal to study a study to compare the safety and efficacy of 2 ophthalmic viscosurgical devices, Viscoat and 2% HPMC.
Good morning, respected teachers. I am presenting a study which compare the safety and efficacy of 2 ophthalmic viscosurgical devices. One is Viscot and another is 2% HPMC. It's a prospective randomized comparative study at SMS Medical College. There's no financial disclosure. Cataract surgery is now an ambulatory surgery with near instant visual recovery. This has been largely due to small incision, optimum use of phaco energy, safe irrigating fluid, and all of the above the evolution of the ophthalmic viscosurgical devices. The ophthalmic viscosurgical devices are basically categorized into categories. One is dispersive and other is cohesive. We can understand well with this picture. It's a full spectrum of OVDs. The dispersive OVDs are basically have ability to coat and partition the anterior chamber, and it's provide the endothelial cell protection during the from the ultrasound energy of phaco and from the nuclear fragments. And the cohesive OVDs has ability to maintain the space and pressurize the eye well during the capsulorhexis. The OVDs which we used during our study was a medium viscosity dispersive OVDs, which is Viscot. Despite the effect of dispersive OVDs, it also provides the space maintenance because of its viscosity, and the HPMC is a very low viscosity dispersive OVD. Our objective was to compare the pre and post-operative values of following parameter during the phacoemulsification. One is best corrected visual acuity, central corneal thickness, and endothelial cell density. We also compared the intraoperative values, which is effective phacoemulsification time and volume of Valen salt solution. We have also evaluated the post-operative IOP spike pattern in both the groups and also documented the intraoperative and post-operative complications. We have recruited the 122 subjects with grade 2 and grade 3 nuclear cataract in 2 groups. That was a randomized distribution. These was the phaco parameters which was used. The power limit was 65% on linear mode, and pulse rate was 60 pulse per second with 30% on time, and vacuum was 360 mm of Hg. It was a result showing that the mean effective phacoemulsification time and BSS values was comparable between both the groups. So it is indicating the similar intraocular insult at the time of the surgery. So it is eliminating the potential effects of these variables on the corneal endothelial cell count. The endothelial cell loss was loss between the preoperative level and the 3rd month post-operative follow-up level was 9% in the HPMC group and 5% for the group B, that was a Viscot group, which is clearly indicating that Viscot is better in protection of corneal endothelial cell density. Central corneal thickness was increased in both the group on the first post-operative day, but it was significant only in the HPMC group compared to the Viscot group, but it reaches to the baseline level at the end of the follow-up, which was 3 months. The mean BCVA was found to be better for the Viscot group than HPMC group on the first post-operative day significantly, which might be due to the increased central corneal thickness in HPMC group. In terms of IOP, there was no significant difference is found between both the groups at each post-operative visit, which because of the wash of OVDs from the anterior chamber and behind the IOL. There was 2 post-operative complication was noted in the HPMC group, which was TAS, and they were which was recovered after the treatment or also included in the study. There was no complication was noted in the Viscot group. The development and innovation that have occurred in world of viscosurgeries over the past 30 years have greatly enhanced our ability and reduced our complication rate in cataract surgery. But there is no OVDs developed till date which has all the characteristics of ideal OVDs, and there is no single preferred and universally accepted OVD. In our study, we have Viscot provided the greater endothelial cell protection and fewer post-operative complications. And we can conclude that the Viscot is more efficient in reducing the endothelial cell damage and safer than HPMC during the phacoemulsification. But both are equally efficient in providing clear cornea and visual acuity 3 months after the surgery. Thank you.
So for grade 2 cataract, what is your choice?
Yes. So,
grade 2 cataract you are going to operate, you will use Viscot or HPMC?
So because they are both are providing the equal
some
visual
protection
acuity
and the difference is not is known to everyone, so there is nothing new in it. What was the reason you wanted to do this study?
Sir, basically a reason was there was no direct comparison of these 2 OVDs.
No, it is available. Okay, thank you. So now I invite the last Dr. Surbhi Khandelwal, study of correlation of OCT biomarkers and BCVA in 100 retinal vein occlusion cases post anti-VEGF.
Good morning, sir. I would like to start my presentation. The aim of my study is to study visual prognosis of retinal vein occlusion based on OCT biomarkers. Objective to evaluate spectral domain OCT feature biomarkers associated with baseline vision and visual outcomes after 6 monthly ranibizumab injections. in prospective study from December 2020 to May 2022. So 100 participants were taken into 18 months, and it is a prospective case who have received anti-VEGF as a primary treatment with or without scatter laser with minimum 6-month follow-up, and were correlated with all the 7 important biomarkers. Inclusion criteria: patients diagnosed with RVO, patient should be conscious cooperative, and they should be cooperative with the OCT procedure. Exclusion: we have excluded the patient who have already received the anti-VEGF injection and any associated retinal pathologies such as diabetic retinopathy, ARMD, telangiectasia, microaneurysms, other radiation retinopathy, and other cataracts. Methods and materials: complete ophthalmological examination was done with BCVA, NCT, slit lamp with plus 78D and 90D, direct and indirect ophthalmoscope, and spectral domain OCT was done. So this is a picture showing the difference between the time domain and the spectral domain OCT. Now, based on the international nomenclature for OCT panel consensus, biomarkers were defined. Spectral domain OCT images were assessed on central subfield thickness, presence, location, and amount of intraretinal or subretinal fluid cyst more than 15 mm, presence, location, and amount of hyperreflective foci, drill, ELM, ellipsoid zone, and the interdigitation zone disruption, neurosensory detachment, and retinoschisis. And univariate and multivariate regression analysis was done. Now, intraretinal cyst, these are the pictures showing the intraretinal cyst and CRT, retinoschisis, hyperreflective foci, ellipsoid zone dysfunction, and the drill, neurosensory detachment. On my observation and results are, table 1 are showing the demographic features, which shows that most of the patients landed up between 56 to 65 years of age. Gender-wise, male were more common. Table 4 is showing type of the RVO in study, and most common were the BRVO. The logmar vision, most of the patient had logmar vision more than 1, that is, vision was less than 6/16 in 54% of the cases. Association of visual acuity with BRVO and CRVO. So the patients were divided between the BRVO and CRVO, and amongst the CRVO, 61% of the patient had vision logmar more than 1, that is less than 6/60. Baseline biomarker status. So when the patient presented to us at that time, all whatever the biomarkers were present, maximum was the drill and ISOS junction, that is 76 and 67% respectively. Association of baseline biomarker with visual acuity. So this is the baseline biomarker with visual acuity. Size of the cyst when it was present. In 76% of the patient, the vision was better, and retinoschisis and hyperreflective foci, the vision was less than 6/60, and this is statistically correlated. This table is showing the association of biomarker with BRVO and CRVO, and this shows that neurosensory detachment was present in 91.5% cases of the CRVO, which is statistically correlated. Effect of ranibizumab on different biomarker. This is an important table which shows that when the ranibizumab was given, so suppose it is in the retinoschisis, it was positive before injection. In 62% of the patient it was present. After injection, 52% of the patient it was present. 10 patient had improved with the vision, or the biomarker has reduced, and this is statistically correlated in neurosensory detachment, ISOS junction, drill. Now, effect of ranibizumab on vision and CRT. Pre-injection, the logmar vision was more than 1, that is less than 6/60. Post-injection, it was logmar 0.4, that is around 6/18. And the central retinal thickness, why we have taken, because most of the study takes the central retinal thickness. Now, this is multivariate regression analysis. Multivariate regression analysis takes all the data simultaneously, starting from the demographic to the drill. And it found out that the lower age size of the cyst, which is less than 15 micron, and CRT more than 500, are found to be significantly associated with higher change in visual acuity after ranibizumab injection. Discussion, there were multiple studies done, but none of the study was done accordingly. According to us, Mimomi and colleagues, they correlated drill and ELM. Moon et al., they correlated the refractive BRVO related macular edema. Shore study, it included VMA, VMT, and ERM, and it was excluded in our study. So the conclusion is, after univariate analysis, patient with retinoschisis, hyperreflective spots, and poor baseline vision, patient with cyst less than 15 micron have good visual prognosis. Most common biomarker is NSD. And in multivariate regression, younger patients cyst size less than 15 micron central tunnel thickness is a good visual prognosis factor. Strength of my study was we analyzed large cohort group and there was a well-defined inclusion and exclusion criteria, and we used the SD-OCT. Limitation was it was limited only with the SD-OCT and we did not use FFA or OPTA. And there are some cases which are showing the images. This is the 3rd month follow-up. It shows that it is a case of BRVO and there is a complete disappearance of the large and the small cyst. And this is also a case of BRVO where CRT more than 500 has reduced. And this is a case of CRVO where large intratunnel cyst was present. So only the size of the cyst and the number have reduced. These are my references. Thank you.
That you chosen the anti-VEGF in all RVOs, or it is just to have the study?
So this was for the study, obviously. It was with or without the scatter laser.
Okay, so you can decide or give us the difference when you are going to use anti-VEGF or steroid in
Yes.
RVO.
Sorry, sir.
Do you have any parameters to say that these patients are better to do anti-VEGF and these patients are better to go with steroids? Meanwhile, I will request all the presenters who are here to receive certificates just after this discussion. Yeah.
Okay, so sir, in RVO cases, we have given anti-VEGF as the first line of treatment.
Okay,
Yes.
and one particular anti-VEGF or the variety of anti-VEGF
Ranibizumab.
to everyone?
Yes, sir.
Okay, thank you.
Thank
Very
you,
good data and study. So first of all, you collect your certificate from here, from Dr. Mukesh Sharma. Yeah, okay. We'll call the name and
Any other presenter who has not received certificate?
Of the competitive paper presenters, I'd like to tell you that presentation is for 6 minutes. The mic will automatically get off after 6 minutes. You may be asked pertinent questions from the judges only. The audience or the people otherwise are not supposed to ask questions to the candidates. Okay? And we have order of the presenters. We'll call them one by one. There's a warning at 1 minute on also.
Yes sir, 5 minutes पे warning है, 6 minutes पे off. So it's coming in 2 minutes. अब चालू तो करना है? हाँ, sure. बुला लो. हाँ. Photocopy हो गया? हाँ.
So the first presenter in this competitive session is Dr. Jyoti Meena. We have no title of your presentation, so that will not be counted if you just tell us before.
Come.
Okay?
Where is the content? Speaker content.
Present तो है ही.
Good morning, everyone. I'm Dr. Jyoti Meena. I'm here to present a study to evaluate long-term outcomes of tin patch graft in corneal fistula. Corneal fistula is a communication between the AC and the corneal surface, follows either trauma or ulcer perforation. It does not heal spontaneously
Start the stop clock.
Because of poor tissue apposition and persistent aqueous humor flow. It can lead to complications, spas, secondary glaucoma, recurrent hypotony, thesis bulbi, endophthalmitis, and panophthalmitis. There are multiple surgical approaches for the corneal fistula that are conjunctival grafts, bandage contact lens, tarsorrhaphy, AMG, and complete corneal grafting. But all these have some side effects, like conjunctival graft can cause reduced visual ability, bandage contact lenses can cause foreign body sensation, and cyanoacrylate glue is a toxic to corneal endothelium. Tarsorrhaphy can cause cosmetic inacceptance and patient dissatisfaction. AMG can cause AMG is difficult to handle, non-transparent and flaccid. Complete corneal grafting has a high chance of endothelial rejection and require extensive use of topical and systemic steroid. Tin patch graft is a very good alternative for the impending perforation or small corneal fistulas because it is a cost-effective, easy availability, autologous nature of tissue which causes less rejection, minimal post-operative inflammation, and simple surgical technique which prevents the urgent need of penetrating keratoplasty. My study type is a prospective interventional study, which we included 10 cases with corneal fistula less than 2 mm. We had a period of 6 months from 1st May 2022 to 31st November 2022. My aim is to evaluate the long-term outcomes of tin patch graft in corneal fistula less than 2 mm to evaluate the time of healing and stability of corneal surfaces. My inclusion criteria are corneal fistula less than 2 mm with positive Seidel's test and patient who are willing, well-informed, written consent. Exclusion criteria are corneal fistula size more than 2 mm and patient which has any ocular or systemic disorder and non-cooperative patients. In our techniques is tin patch graft size measure and superior temporal conjunctiva more than 1 mm is taken. Linear peritomy is done, tenon tissue mark using calipers and incision over the tenon. The tenon tissue correspond to the size of conjunctival marking is excised and the cut edges of the conjunctiva are approximated. The procured graft is trimmed to match the size and shape of the defect and the graft is then sutured with using 10-0 nylon suture. At the end of the procedure, anterior chamber is formed with the air. Our result is pre-operative and a post-operative picture of day 7. Gender distribution we included 10 cases in which 6 are females and the 4 are male patients. We achieved 80% patients successfully achieved globe integrity and anterior chamber was formed and 20% patients, only 20% patients shows fluorescent leak. Anterior chamber formation was observed on day 1 of grafting in which 8 patients show no leak on Seidel's test. Our patient shows the BCVA improvement from 0.311 to 0.118 with a p-value of less than 0.01. Baseline BCVA no statistically significant difference and the difference was statistically highly significant post-operatively. Open corneal fistulas are abnormal communication between anterior chamber and corneal surfaces. If left untreated, it may lead to many complications. Our primary goal of treating corneal perforation is restore eye integrity and promote healing of a potential future corneal transplantation. In developing countries, there are many issues like cost limitations, scarcity of donor cornea, and maintaining eye bank and stem cell laboratories. In which tin patch graft shows a beneficial like
It can improve BCVA and IOPs, minimal post-operative inflammation, reduce risk of rejection, cost effectiveness, relatively simple surgical approach. Minimize potential complications with tissue adhesives, post-operative inflammation, vascularization, and ocular discomfort. My conclusion is
Yes or no, present.
my study TPGA has a good success rate, cost-effective,
Two,
improved
present.
BCVA and IOP, easy availability, autologous nature of tissue which cause less rejection, no rejection at all, minimal post-operative inflammation, and simple surgical technique. Thank you.
Thank you, Dr. Sujyoti. Tell me, what type of anesthesia you used for it?
What type of anesthesia is used for? Sir, local.
Pardon?
Local anesthesia is.
Local means you
Sir.
injected.
Yes, sir. Yes, sir.
Local means you injected.
Yes, sir. Lignocaine, bupivacaine combination. Yes, sir. Injected. Yes, sir.
It was subtenance
Yes, sir.
or a periocular.
Sir, periocular.
Periocular. Okay. What is new about your study?
Yes, sir. Sorry, sir.
Because what is new about your study? Because these things have been done in the past for number of decades.
Yes, sir.
So why did you choose to do it? What was the aim of choosing this particular study?
Yes, sir. Because sir, it is very cost limiting, and sir, autologous nature of tissue causes less rejections or no rejection at all. And so it has many in less than 2 mm corneal fistula. It is very beneficial because it's cost limited, simple surgical technique, no need of cornea and donor requirement. That's why sir we choose TPG.
You see, all these cases which you have shown looks like an active corneal ulcer with perforation,
Yes, sir.
with a lot of infiltration around,
Yes, sir. Yes, sir.
isn't it?
Yes, sir.
So when do you choose to do it as a graft or as a BCL, as you had mentioned earlier, with cyanoacrylate glue?
Yes, sir.
So what is the advantage of doing it
So-
in an acute case?
So acute cases means sir advanced post-operative. We've seen that more than 80% cases achieve the globe integrity very well, and there is no fluorescent leak at all. And sir, after 1 month, the BCVA is also improved and IOP is also within the normal range.
You see, we don't bother about the BCVA in these cases, which has got a central dense corneal opacity with a perforation. We just want to keep the integrity of the eyeball,
Yes, sir.
basically. Don't you think that when you put a tenous graft, it encourages vascularization?
Yes, sir.
It does it?
Sorry, sir. I didn't hear.
When you give a tenous graft, or BCL with cyanoacrylate glue, otherwise.
Yes, sir. Glue
So
can
does
cause-
it
Yes, sir.
enhances the vascularization, which helps in healing also?
Yes, sir. Sir, it helps the cornea with the regenerating the nature.
This is what I mentioned
sir.
when you would have stressed that cyanoacrylate glue with, as you said, it is expensive one, definitely. It has got a toxicity, that's
Yes,
very true. And it get dislodged also many times. You have to repeat it also.
Yes, sir.
But the advantage of your study is that it is not only seals it,
Yes, sir.
but enhances the
Sir, regenerating nature of cornea.
the
Yes,
healing
sir.
process
Yes.
also.
I've got two questions for you. One, how does a corneal fistula get formed?
So
One.
it can be
Yes,
because
please
of
answer.
many causes like traumatic, infectious.
No, I'm not asking you the
Yes, sir.
etiology.
Yes, sir.
What is the basic pathology of formation of a corneal fistula?
Sir,
How
corneal
does a fistulous tract get formed? Anywhere in the body?
Yes, sir. Sir, corneal fistula is a communication between the anterior chamber and the corneal surface.
True.
It is yes, sir.
But
Non-healing.
what makes a fistulous tract between the anterior chamber and the cornea? Very simple. If you
continuous act-
listen to me,
Yes,
if
sir.
you recap your pathology knowledge, you would recap that for any fistulous tract to get formed, it has to get epithelialized. Okay? So some of the epithelial cells,
Yes, sir.
along with the traumatic material or whatever it is,
Yes, sir.
they travel the track, they epithelialize the track, and that is how a fistula
yes, sir,
gets
fistula
formed.
is formed. Yes, sir.
Two, we have many other options available
Yes, sir.
for taking care of this kind of problem.
Yes, sir.
How would we justify your method to be better over other available options?
So our method is better because in less than 2 mm of fistula, TPG is a very simple surgical technique. No need of cornea and knee donors, and so it's like in glue it can cause infection, inflammation, and so conjunctivitis and all. It also can cause secondary glaucoma. In TPG, it is non-infectious, like because it is a autologous nature of tissue and it causes less rejection, no rejections. That's why we choose the TPG.
How would you justify over TK?
Yes, sir.
How would you justify this procedure over TK?
So that was a complicated surgery, sir, or it can cause.
Enough. Okay, thank you.
Okay, thank you, sir.
On the next one. Mansi.
I have the pleasure of calling Dr. Mansis
Sonwar.
for her presentation.
Good morning, everyone present here. I am here to present on the topic of comparison of OCTA parameters before and after intravitreal injection ranibizumab in retinal vein occlusion patients. So why OCTA? Why OCTA angiography is required? Since it is a non-invasive, quick and 3D method for imaging, it does not require a dye injection. It enables a high resolution and rapid imaging of bloodstream in various layers of retina. It helps in analysis of distinct vascular layers of retina, including the superficial and deep capillary plexus. The in-phase imaging enables the image of a normal foveal avascular zone and its changes in macular involvement. It uses the split spectrum amplitude decorrelation angiography algorithm to detect atheroids movement. Now, what is the principle for OCTA? As the word optical itself says that it uses light. Coherence means two light waves with a constant phase difference. Tomography means imaging of sections. Angiography means imaging of blood vessels. What are the OCTA findings we can get via OCTA in retinal vein occlusion patient? Capillary non-perfusion corresponding to area involved, FAZ enlargement, microvascular abnormalities, vascular congestion, collateral formation, neovascularization, and macular edema. Retinal vein occlusion is the most common cause of retinal vascular disease and vision loss. The most important cause of visual impairment in RVO is macular edema. Macular edema is caused by the release of substances that enhance vascular permeability, such as VEGF. VEGF is produced in the retina because of the deterioration of tight junctions between capillary endothelial cells and adhesions between the vitreous and the retina, damaging the blood-retinal barrier. So, the anti-VEGF drugs are used frequently in the treatment of macular edema due to RVO. For this study, we evaluated the effect of anti-VEGF injection treatment in eyes with retinal vein occlusion using OCTA by comparing the baseline eye, that is the RVO eye, before and after treatment, and comparing it with the contralateral eye. We assessed the vessel densities of superficial capillary plexus, the central retinal thickness, and the FAZ areas of OCTA in patients who underwent anti-VEGF treatment. The aim of my study is to see changes in optical coherence tomography-based angiography biomarkers after anti-VEGF injection in macular edema due to retinal vein occlusion. Objectives include pre- and post-injection analysis of central retinal thickness, the foveal avascular zone area analysis, and vessel density in the superficial capillary plexus. Selection criteria: inclusion group, the age group is 35 to 85 years of age with the recent episode of RVO, with presence of macular edema, a minimum follow-up of 3 months, and patient who give a well-informed written consent. Exclusion: uncooperative patients, uveitis, uncontrolled glaucoma, vitreous hemorrhage, big media opacity, a poor signal strength on OCTA less than 2, a previous history of anti-VEGF, ocular infections, ocular trauma, and surgery. Study methodology: this is a single center interventional type of study with the well-informed written consent was taken with patients. A study recruited 30 patients, including 18 men and 12 women, who have undergone anti-VEGF injection in a single eye with macular edema due to RVO, diagnosed with the help of fundoscopy and spectral domain OCT. A brief history and a complete ocular examination was done. Each eye is undergone OCT angiography with the analysis of all the parameters mentioned earlier. A follow-up was done at 1 month and 3 months, and stat analysis was done. The results of my study concluded that the central retinal thickness, as we compare the
Post-injection, after 3 months of injection, the RVO-I shows a significant decrease in the central retinal thickness. In the parafoveal vessel density of superficial capillary plexus, there is a decrease in vessel density, but the decrease is not so much significant after 3 months of injection. In the FAZ area, as we compare the RVO-I FAZ area pre-injection and post-injection, we can see that there is decrease in the post-injection FAZ area, and when we compare the RVO-I with the fellow eye, there is also a significant difference seen in the fellow eye. This is the image showing the before treatment and after treatment. The first image is the OCTA image showing the disruption of the parafoveal vascular arcade and the FAZ with cystoid spaces in superficial capillary plexus. And we can see the significant change after treatment in the image itself, that after 3 months, there is an intact vascular arcade with the resolution of macular edema showing in the B scan mentioned below. Discussion. A significant decrease has been shown in the patient of RVO and macular edema treated with anti-VEGF injection. When compared with unaffected eyes of patient before treatment, we found the FAZ areas in RVO-I to be significantly larger than those in the fellow eye. The FAZ area post-injection improved significantly. In the RVO-I, we also noted a decrease in vessel densities at the parafoveal superficial capillary plexus compared to those in the treated and contralateral eye, but the change after anti-VEGF injection was not so significant. The cyst also decreased in both the plexus. The results of our study shows concordance with the study done by Dogan NC et al., which shows that after monthly injection of anti-VEGF injection, there is a significant decrease in CRT and there is a improvement in BCVA. So in conclusion, we can say that OCTA showed significant regression of macular edema, reduced capillary disruption and cyst, and parafoveal vascular arcade improvement. It enables both qualitative as well as quantitative evaluation tool for the follow-up of patients for RVO, thus enabling us to predict the visual prognosis in RVO patients who have been treated with anti-VEGF injections. So these are the references. Thank you.
See, now what is the aim of your study? You're studying OCTA or you're studying the effect of anti-VEGF? Oh, yeah, it's not clear in your discussion. You're harping on anti-VEGF, but last minute OCTA ke baare mein bola. What is the aim of your study?
So mainly studying the parameters of OCTA angiography.
So that you have not emphasized in your discussion.
The single cell anti-VEGF injection, that is ranibizumab.
So anti-VEGF, we all know it has a role in that. But OCTA should have been brought up in a discussion, which is not brought up one. Second, how is OCTA better than a normal OCT for evaluation of macular edema due to BRVO or CRVO?
So since we are studying the angiography, so we can predict the cysts which are forming or macular edema in the deeper layers at an earlier stage as compared to that in the OCT. Because if
no, you already said you're examining the FAZ, which is very important in OCTA.
Sir. FAZ is also being analyzed.
Then you can also detect new vascularization. But also, so you don't lose heart, you can always do an angiography in OCT. That's similar actually. It's not a very paradigm jump in investigations. Now, you have not mentioned what anti-VEGFs you used?
So ranibizumab.
So you should have mentioned that actually.
I have mentioned.
You mentioned? Okay, I missed it. Now tell me, when will you use a anti-VEGF, when will you use a steroid in RVO?
And which is preferred one?
Which one? Like Ozurdex, you know Ozurdex? Okay, doesn't matter if you don't know. It's okay.
In continuation to Dr. Pawan Shore's question, are steroids outdated as far as the treatment of vein occlusion is concerned?
Sir, please pardon.
Do we still bank upon steroids for taking care of CRVO, or now they are obsolete in lieu of newer options available?
Sir, these I don't think so. The steroids are being used. They are contending. Sir, anti-VEGF are more preferred in RVO patients, sir.
I still differ a little bit, and I think for Pawan Shore will endorse it. The venous occlusion induced edemas respond better than better by steroids than anti-VEGFs.
So because the main pathology is because of the VEGF release, so sir, if we give anti-VEGF.
In the fresh ones, I'm sure it's steroids, and the advantage is that if you're giving Ozurdex, It's for 3 months. Here you have to give it every month. And steroids definitely give a better response, but also comes with the rider that there's always a chance of glaucoma in that. So the safer, gambit for us is to use anti-VEGF than this. Thank you.
Thank you, sir.
Dr. Zeba. Next
It's
is
now the turn for Dr.
Zeba Shaheen.
Zebrat Shaheen.
Good morning, everyone. Myself, Dr. Zeba Shaheen. I'm here to present my paper on the topic of ocular trauma, how it is affecting the social, psychological, and economic aspect of a life of individual living with a traumatic eye.
When you are presenting in a competitive paper, never add a name of your co-colleague. It get bashed.
These are the headings we will cover our topic under which, as per the WHO Blindness Data Bank, approximately 55 million eye injuries occur worldwide annually. In India, over 50 million people suffer from blindness. Among them, 1.2% cases of blindness are caused by the avoidable ocular injuries. Ocular injury is a significant cause of blindness worldwide that negatively affect the quality of life of patients, their families, their socioeconomic status, and their psychological well-being. So the basic aim of my study is to assess the outcomes of the ocular trauma in terms of visual disability and its effect on the social, economic, and psychological aspect among the patient surviving with the traumatic eye. Objective of this study was to provide the recent epidemiological data on recent trends of the ocular trauma and examining the presence of visual damage due to the ocular trauma and assess the visual outcomes. This is a hospital-based longitudinal observational study. 200 patients were enrolled who presented with the eye injury through the OPD or the emergency route. The patient underwent a complete ophthalmological examination, including for the visual acuity testing, slit lamp examination, and fundoscopy where possible. The inclusion criteria was the patient with the ocular injury, only globe involving injury, and the only anterior segment involving injury, reporting to the OPD and the emergency who are agreed to give written consent. 18 to 60 year age group were included. Those having exclusion criteria was those having the pre-existing vision-threatening ocular diseases like glaucoma, age-related macular degeneration, injury in a blind or atrophied eye, comatose or unconscious patients who were not agreed to attend the regular follow-ups. A total 200 patients with the ocular trauma were included and prior informed consent was taken. Detailed history was taken about all the demographic details, specific history of trauma were included, and all the information was collected in a pre-designed performa. A detailed interview of the enrolled patient conducted at the 3-month follow-up visit to know about the impact of ocular trauma on different aspects of their life. These are my study tools to assess the results. Detailed history of trauma events, Snellen chart for the visual acuity, slit lamp examination for the detailed ocular examination, direct or indirect ophthalmoscopy examination where possible, EQ5D5L questionnaire to assess the quality of life of the patient, detailed interview about the different aspects of the life. EQ5D5L is a self-assessed health-related score which measure the quality of life on a 5-component scale: mobility, self-care, usual activity, pain, discomfort, or anxiety and depression. These are my results. Out of 200 patients, majority of patients were male and the most vulnerable age group was 18 to 30 years. Majority of patients were illiterate. Among all the participants, 42% were students and rest were engaged in different activities like 20% were farmers, 16% laborer, 13% housemakers, 9% was in service. 62% patients belong to the rural background. The most occupational injury accounted for 24%. Among the non-occupational injury, the sport-related injury was the more common. 74% patient presented with the mechanical trauma. Among the mechanical trauma, wooden objects was the commonest. Most of the patient presented with the perception of light or hand movement or the finger count visual acuity. Open glove injuries were common and penetrating laceration was the commonest. These are the compilation of all the demographic details on the basis of quality of life assessment. We assess the mobility and self-care is not much affected just by the ocular trauma, but the pain, discomfort, and anxiety, depression was a significant issue in the patients.
A detailed interview was conducted and patients were asked about the following domains of their life: workplace life, married relationship status, or the social life. And their response noted at the scale of not at all, a little bit, moderately, quite a bit, and extremely, that correspond to the score of 0 to 4. These are the results on the basis of the response of the patients, and it conclude that the ocular trauma significantly affect the work life of the 61 patients who face the discrimination on the workplace or the school due to their physical appearance. Around 11% faces the extreme difficulty, like they lost their job or having difficulty to get the job that leads to the financial crisis to them. 59% patients were struggling with the relationship problem. 7% was got divorced or broke up. After ocular trauma, 78% patients having anxiety, depression, and self-doubt issues. Among them, 73% patient does not seek any psychiatric treatment due to the social stigma. Around 70% patients start to avoid social events because of the self-doubt and lack of confidence in their physical appearance. So the conclusion was a study that ocular trauma influences the quality and mental well-being of a patient. A healthy eye and the visual acuity is very important for a good physical appearance and the confidence of the patient, as the financial cost associated with the ocular trauma and the economic burden on the healthcare system also, resulting from the cost of treatment and rehabilitation services. So the rising awareness and implementing the prevention measure are highly justified. On the other hand, accepting the eye injury and living with its result is a serious process for the people, specifically for young generations. Therefore, psychological and psychiatric support is needed in the follow-up of subjects suffered from the eye traumas. Thank you.
So, take-home message for this from your paper?
So my take-home message is that ocular trauma is preventable
No, for people who already have ocular trauma, you have already mentioned in that. What is your take-home message for them?
So has already ocular trauma, my take-home message for them is, if you are facing any psychiatric symptom, if you are feeling low, you can
Take help.
consider
Yeah.
psychiatric treatment or the psychiatric help. There is no shame in that. Anxiety, depression is not a disease. It's not normal for anyone, and you can seek the treatment. It's no shameful. It's not a social. It should not be a social stigma. Actually.
And also another thing you should have said about the prevention in sports injuries, especially.
Sorry, sir.
Prevention in sports injuries. That also you could have talked in that.
Prevention sport injuries. So like.
No, I'm saying you could have included that in this. Anyway, it doesn't matter.
These 200 cases, they were the total number of cases, or you have selected those cases who presented in follow-up regularly?
So who presented or follow-up regularly, actually.
It's a good work done in the field of community ophthalmology. I appreciate it. But what is your carry-home message for the audience sitting here in the hall?
So the patients who present with the ocular trauma, they actually need the acceptance, and more the audience can do for them is to accept them. Actually, it's not their problem, it's society problem who does not accept the patient or who would discriminate the patient on the physical appearance of the patient, actually.
So you must stress upon that there is a very important need of an early rehabilitation, whether it's a physical one or economical one or a psychological one.
Sorry, sir.
Rehabilitation of these patients, which includes a physical rehabilitation if possible, a psychological treatment as you suggested, again to be in the mainstream of the society, and rehabilitation as far as economic is concerned, so that they can earn their living. If they are able to earn their living their own, half of the psychological problems are solved.
Yes, sir.
And then, even if they are one-eyed, the look is not very good, I must say. It's not a bad one. But if they are financially well off, economically well off, they will be taken or perceived in the society in a better way. So these three factors, the factors in rehabilitation: one, physical; another is psychological; and third is economical. All these factors should be looked after. And early rehabilitation, if it is not done early, then they go in a phase which you cannot bring them back.
Yes, sir.
Did you do anything in terms of rehabilitation of these people as a part of your study, or just as a follow-up? Because rehabilitation of these cases is of paramount importance, isn't it? As
Yes,
far as
sir.
our society framework is concerned, the stigma you know.
Yes, sir. We actually suggest our patient to seek the psychiatric treatment because we just make them understood about the psychiatric or the professional that can rehabilitate them that we can't actually.
Thank you, ma'am. Now I call upon Dr. Monica for her presentation.
Good morning, dear judges and my fellow colleagues. I am Dr. Monica Bagla. I am here to present my paper on comparison of three different types of hydration techniques in clear corneal uniplanar incision phacoemulsification surgery. As we all know that during phacoemulsification surgery, we make a clear corneal wound of around 2.8 to 2.2 to 2.8 mm. The integrity of the clear corneal wound is extremely important to achieve excellent outcomes during as well as after the phacoemulsification surgery. After the completion of phacoemulsification of the lens nucleus and intraocular lens insertion, a watertight seal of corneal wound is needed to prevent any egress of anterior chamber contents outside the eye, thereby preventing hypotony, and it also prevents accidental seepage of ocular surface contents inside the anterior chamber, thereby reducing the risk of endophthalmitis to a larger extent. In the view of these benefits, every surgeon aims for a watertight wound closure at the end of the surgery. I have included three hydration techniques in my study. First one is conventional stromal hydration, second one is anterior stromal pocket hydration, and the third one is hydration using a 30 gauge needle. This study was conducted at Sahai Hospital and Research Center, Jaipur. It was a prospective randomized comparative study. All the patients were divided into three groups with 20 patients in each group according to the type of hydration technique they underwent. In group 1, I have included the patients who have undergone conventional hydration technique with 27 gauge cannula. In this technique, we hydrate the main incision by hydrating the lateral walls and the roof of the anterior stromal tunnel. In group 2, I have included patients who have underwent hydration using an anterior stromal pocket. In this technique, an anterior or supraincisional stromal pocket is made overlying the internal entry site of clear corneal incision. And in group 3, I have included patients who have undergone hydration using a 30 gauge needle attached to a 2 ml syringe containing balanced salt solution. Wound was hydrated by burying the needle into corneal stroma. In this video, I will be showing anterior stromal pocket hydration. As we can see, firstly, we are making a pocket which is just supraincisional to our main corneal wound, which is being made using a keratome, which is around 2.2 to 2.8 mm in length. And this supraincisional pocket is triangular in shape and around 0.75 to 1 mm. Now in this further video, I will be showing hydration using a 30 gauge needle. In this video, we are after completion of the phacoemulsification of cataract and intraocular lens insertion, now we are hydrating the main incision and the side ports using a 30 gauge needle by just burying the needle into the corneal stroma, which is done just beyond the entry of the clear corneal incision. As we can see, the hydration being done until the visible whitening of the cornea. Now in this further video, now we will check the wound leak post hydration. In this video, we are checking the wound leak by just pressing the posterior lip of the wound with the help of a cotton bud, and we can see that there was no hydration, no leak after the hydration using a 30 gauge needle. Now, for an ease, I have tabulated the results in three groups, which is number of times we have to hydrate leakage due to pressure on posterior lip of wound and on the basis of post-op wound leak. We have to hydrate the thrice in 25% and twice in 50% of cases in group 1, which is conventional stromal hydration. And in group 2, that is anterior stromal pocket hydration, we had to hydrate twice in 30% of our cases. And in case of hydration using 30 gauge needle, we had to hydrate twice in 5% of cases. And during leakage due to pressure on the posterior lip of wound, leakage was seen just in one group, which is conventional stromal pocket hydration, and it was seen in 3 cases, that is 15%, and no leakage was seen on pressure on posterior lip of wound in group 2 as well as in group 3. And as we come to post-op wound leak, post-operative wound leak was not seen in any one of the groups. After the following study, we came to conclusion that hydration with 30 gauge needle is a useful sutureless technique, especially in young and pediatric patients, to seal leaking phacoemulsification wound in single attempt, and also to avoid complications related to post-operative wound leak and excessive wound hydration. Thank you.
Thank you, Dr. Monica. Tell me 2 things. How far beyond you are going with the 30 gauge needle? I mean, the entry to the anterior chamber.
So we are going just beyond the internal entry site of our clear corneal incision.
And how much is the length of your clear corneal incision?
So it's around 1 to 2 mm, sir.
Only?
Length 2.2 to 2.8 mm, sir.
You are using a keratome of 2.4 or 2.8?
So in this study, we have used 2.4, sir.
2.4.
Yes, sir.
And are you doing most of the surgeries in 2.4, which is
So-
MICS? Normally, 2.4 is usually done with MICS, which is not done in every case. So what is, say, how big you make the incision for phacoemulsification? Maybe it is ICS or MICS.
So it's around 2.2 to 2.8 mm, sir.
2.2?
In general, sir, 2.2 to 2.8 mm.
I'm
But in
amazed that you are doing phaco with 2.2.
In regular practice, sir, it is done 2.8, sir.
So you initially mentioned 2.2 and 2.4, then you made 2.8. Okay, 2.8 justified, but 2.2. Another thing is, you said in pediatric patients, you see it is said and it is known that all pediatric patients, especially very young patients, in spite of doing hydration, they may have a leak. And we want to put a single suture.
Yes, sir.
Because there's a very high chances, and you advocate that is better.
Yes, sir, because in pediatric patients, collagen fibrils are very elastic, sir. So it is a very useful technique to hydrate, and it is a sutureless technique, sir. My leak was not seen.
That is the reason that they leak. And you want to put a suture.
Sir,
The hydration in adult, if you do a good hydration in adult, it seals and seals very strong sealing.
yes, sir.
But if you do the same hydration in a pediatric patient, say about 2 years or 3 years, you need to put a suture, otherwise chances of leak are very, very high.
Yes, sir, but the chances of leak are high in conventional hydration and as well as in interior stromal, sir. But the chances of leak in those patients are less with 30 gauge needles, sir.
Your age group was 18 plus, isn't it?
Yes, sir. In this study, 18
Okay.
plus. Yes.
Manisha, when you talk about conventional wound closure and group 2, what is the plane in which you are injecting in the conventional closure of the wound, and what is the difference between the two?
So in conventional, we are hydrating the lateral walls and the side walls of the main incision, sir.
But what level of cornea you go?
So around in the 1/3 of the stroma. In interior stromal pocket hydration, we go around 1/3 of the corneal stroma.
And what is the plane in group 3?
So uniplanar, sir.
I have my apprehension while seeing your video about group 3 that it may have something to do with the corneal integrity in post-operative period. Did you study about the post-op astigmatism and all that?
Yes, sir.
Amongst the 3 groups? Of course, your basic aim was to check the integrity of the wound closure. That is of paramount importance after you have completed a successful phaco. But did you check about the corneal integrity in post-operative period so as to be more authentic about recommending the third option for wound closure?
The corneal integrity was maintained, sir. It was very well maintained, but I have not checked the astigmatism, sir. But in regular cases, in all the cases, the surgical induced astigmatism was less, sir.
Okay, thank you.
There's a person sitting in the audience here who is said to be a master of SICS. And he does a lot of SICS and the wound closure by hydration. Will you like to comment, Sudhir? She has presented a paper saying there are 3 ways of doing wound sealing by corneal hydration. One is a conventional, which you do normally, and you have not mentioned it which layer, as Dr. Nepali was wanting, that you inject to for the wound sealing. Another one is a pocket which is found beyond the entry in the anterior chamber with 30 gauge needle, which is she compared. And he has been doing phaco as well as SICS, but he has really mastered SICS in some way. Would you like to comment upon?
Yeah, yes, sir. I haven't seen the video, but I would like to just give one small tip. Basically, whenever you are doing the hydration, before that you use air bubble, and your eyes would be hyper tight. Then press it with the swab stick. Then I take a minimum 27 gauge cannula and go in the side, and that will check on the table. Your wound should be watertight. If it is, it's okay. If it is not, then it's not going to. Then do it again. So,
So my question was, what was the need of going for with 30 gauge needle beyond the entry of the entry into the anterior chamber?
So because with the conventional hydration, we have to repeat the hydration, which comes with the risk
It's
of
very rare.
which comes with the risk of desperate membrane.
And you said you had to repeat in 30 gauge also.
So chances are very less with 30 gauge needles.
You see, when you go as closer to the central cornea and you are hydrating beyond, I don't think that the lip which is there and you are hydrating beyond it, it will seal.
So just
I don't know. I mean, maybe. Have you any literature about it?
Thank you, Dr. Monica. Anyway, thanks to you, Dr. Sudhesh, since you are here and you have vast experience of phaco surgery also, and you're a DNB guide also. For the benefit of the PG sitting over here, I would like to have your views about wound closure after phaco surgery. What is your approach?
Yes, on the outside, I would like to say one thing. You are the. I have seen PGs are like participating enthusiastically. All these these are teachers for you. I think so. So take every point and don't take it that they are asking you. They I'm talking to all. They are just inciting something that you should next time work on these things, because questions are always good. Sometimes there is no time for asking questions. For wound closures, always your main part of wound is your wound should be watertight. That is the main thing. So for phaco, first of all, you do whatever you are doing it, and after wound sealing, you should not do anything else. If you are putting the intracameral antibiotic, that should be before the wound tight. So what I do, I take a big air bubble, then give first mechanical closure with that, then I go in the side port hydrations. And as sir rightly saying, because of we are approximating the both lips basically. So this side, and check it. Always you will see the water is coming out. If it's not able to see, then you can put the methylene blue. Always better. Okay?
Thank you, sir.
May I call Dr. Sapna Gupta to come with her presentation?
Good morning, everyone. The topic for my paper presentation is changes in corneal topography after frontalis suspension surgery in patients with congenital ptosis. Congenital ptosis is defined as drooping of the upper eyelid since birth or within 1 year of age. The eyelid pressure in ptosis causes flattening of the peripheral cornea and steepening of the central cornea, which leads to higher incidence of corneal astigmatism and loss of symmetry. Corneal topography of ptotic eye also shows more surface irregularity and asymmetry as compared to normal eye. Various theories propose that upper eyelids cause a band-like pressure on the cornea. This may cause with the rule astigmatism due to altered corneal shape. The aim of my study was to evaluate changes in corneal topography after frontalis suspension surgery in patients with congenital ptosis. The objectives of the study were to measure preoperative corneal topography parameters and compare them with the postoperative values at 6 weeks and 12 weeks to record best corrected visual acuity and study changes in the long term. The study design was descriptive observational type. Sample size was 37 cases and the study time was from January 2023 to August 2023. Patient's preoperative corneal parameters were noted by Scheimpflug corneal topography, the series. Frontalis sling surgery was done using silicone sling with Fox pentagon technique. Corneal topography was done again at 6 and 12 weeks follow-up period. My inclusion criteria were patients who were willing to give informed consent for surgery, patients above 5 years of age diagnosed as congenital ptosis, since the patients less than 5 years of age could not cooperate for corneal topography. The exclusion criteria were other causes of ptosis like mechanical, neurological, and traumatic ptosis, any corneal abnormality due to VKC or dry eye, any previous surgery, or any previous trauma. The mean age of patients were 12.4 years. Among 37 patients, there were 21 males and 16 were females. In result, there was a significant decrease in steepest K post-operatively at 6 weeks. Superior K was also decreased post-operatively, but the decrease was not significant. There was a significant decrease in inferior K post-operatively, which means that the decrease in inferior K was more in post-operative period. SIMK max, SIMK minimum also decreased, but that was not significant. CCT was also not significant. Surface regularity index at 3 mm and 4 mm were measured, and it was not significant. Surgical ptosis repair resulted in a significant decrease of steepest K, which indicates flattening. Both superior K and inferior K decreased after surgery, but the decrease in inferior K was statistically significant, which indicates that surgery resulted in the global flattening of cornea, but more in the inferior hemisphere. Other corneal topography parameters like SIMK max, SIMK minimum, central corneal thickness, surface regularity index were also compared, but there was no significant difference. The post-operative changes in best corrected visual acuity, cycloplegic sphere, and cylinder were also minimal. Ptosis correction surgery resulted in significant flattening and regression of anterior corneal surface to near normal anatomy. This further resulted in improvement of corneal surface regularity and symmetry. Thank you.
Thank you. I think it's a good study, and there is originality also. I don't think that anybody has done this study earlier. Looking at it, the only thing is was it bilateral or unilateral?
So in my study, most patients were unilateral only.
Okay. So what was the status of astigmatism in the other eye? And did it change with the age? The other eye.
Okay.
By this, you have been studying one eye, which is diseased eye.
Yes,
You
sir.
corrected it with the sling. Why
Yes.
sling was?
Silicone sling, sir.
Why sling was used?
The silicone sling was used.
Why?
For the ptosis, LPS section was
You said it's a severe ptosis.
हाँ, sir.
It's a severe ptosis.
Severe ptosis. So
But
LPS
you should have
function
shown.
is poor.
You should have shown some pictures of the ptosis with correction also. You see. Now, have you compared? It is only the severe ptosis. Have you done cases with a moderate ptosis, which also bang upon cornea, causing some changes in the corneal curvature, and do they recover back?
So we only included patients with severe ptosis.
You see, unilaterality, is it severe, unilateral, congenital, simple ptosis?
Yes, sir.
It was simple ptosis, no other abnormality was there.
All other causes.
Simple ptosis, and you corrected it with
Frontalis
a sling
suspension
surgery. Sling surgery in a unilateral case, congenital, the success rate is not 100%, you know it. It can never match with the other eye, which is a known factor, which is known to the patient also, and we explain them also. You see, the advantage you have mentioned is there is a change to the originality in the corneal curvature, which may increase the visual acuity because of decrease in the corneal strength. Your average age group was 12 something. A patient with this age, as this was average, having severe ptosis till date, you should have mentioned the vision may not improve because of the amblyopia. A simple unilateral, you see, unilateral congenital ptosis lasting till this age 12 is your average age.
Yes.
Maybe some of the cases were 16, some of the cases were 8 or something. Will lead to amblyopia. Do you agree or not?
Yes, sir. Congenital ptosis may lead to amblyopia.
So a change in the corneal curvature may not bring about any change in the visual acuity because of the other pathology which is.
Amblyopia. Yes, sir.
Dr. Sapna, you have studied the corneal thickness with Scheimpflug camera, isn't it? Did you use Pentacam or some other?
So serious. Be you serious?
That also has a rotating Scheimpflug camera?
Yes, sir. That is also based on Scheimpflug.
Do you think it is better than those options which work on scanning slit system like OrbScan?
So the serious is better than OrbScan as OrbScan has poor repeatability.
Now, how about LensStar 900?
Sorry, sir?
How about LensStar 900? No idea?
No.
One more question. What is Munson sign?
So Munson sign is seen in keratoconus. When the patient looks down, there is a V-shaped
Depression in the lower lid
lower lid.
in cases of?
Keratoconus. Advanced
Thank you.
keratoconus.
Thank you for your presentation. Sorry.
1 minute, sir. No, how could you gather 35 cases in 6 months? When normally, it's quite a thing, feat you have. In 6 months you've done it. कहाँ से मिल गए तुम्हें इतने? हमें तो कभी नहीं दिखे.
But SMS hospital.
I'm just asking you.
So SMS hospital.
Huh?
SMS hospital.
SMS?
Yes.
Okay.
It's a big series and it's worth reporting. That's good. Thank you.
Okay, sir. Yes, sir.
Thank you, Dr. Sudhir, for your inputs. Thank you, Dr. Sapna. Now we have the last presentation by Dr. Sahil Jain.
Good morning. I'm Sahil Jain. I'm here to give my presentation on a comparison between the changes in the corneal astigmatism and corneal abrasions by giving either 2.4 or 3 mm opposite clear corneal incision during phacoemulsification surgery. Doctor, will I be able to see clearly after the surgery? A quintessential question that every cataract patient asks their doctor before going for the surgery, to which we explain them multitude of things, and a common thread is आंखों की रोशनी लेंस पर्दे व हीरे पर निर्भर करती है. So if in that case the hira and the parda are grossly within normal, then the cataractous lens, after we remove it, what still hampers the vision are the refractive errors, of which the former two, the myopia and the hyperopia, can be corrected by placing the IOL, but what still remains hampering the vision is the corneal astigmatism. So what I'm trying to say is that corneal astigmatism is the most powerful refractive surgery. It can correct anything from -30 diopter myopia to 20 diopter hyperopia to a plano, but it still is unable to rectify the pre-existing astigmatism. So how intraoperatively we can correct the pre-existing astigmatism? More favored option is a toric IOL, but which I feel is rather expensive for developing countries like ours, and also it is unpredictable in its impact when it leads to any IOL misalignment. Another very highly skilled surgeon requiring surgery option is limbal relaxing incision, and it also depends on the healing properties of cornea. So what other option that is possible is this OCCIs, opposite clear corneal incisions, which are rather simple to perform, inexpensive procedures, do not require any extra time, and experience has shown they produce a stable flattening effect. What we do is, as we can see, we just give a two opposite incision to the main port along the steepest axis, and how they basically act is like in the normal corneal tension. When we give a suture, we taut the cornea and we steepen it. Similarly, when we give an incision, we relax that same tension and we can flatten it. So my aim was to study the same by giving opposite clear corneal incisions. I worked up the patient by pre-operative Scheimpflug imaging, and then post-operatively I followed them for 3 months, And based on the three parameters, access and power of the cylinder, higher order abrasions, UCV and BCVA, I followed the patients. It was a prospective interventional study. I included 80 patients, randomly divided 42.4 mm eyes and 40 eyes with 3 mm incisions. So the period was 8 months. I included against the rule 1 to 2 diopter astigmatism patients with properly dilating pupil, and I excluded any patients with any corneal pathology or subluxated lens or any past ocular history. My method as the surgeon started with the surgery was, first the steep axis was marked with the axis marker. This particular patient had 1.22 diopter at 11 degree. Then first we created the main port with either the 2.2 or 2.8 keratome, depending on whether it was a 2.4 or the 3 mm group patient. Then the opposite clear incision was made with the same keratome and it was left patent. And from the main port, the surgery was performed. And after the surgery, first the main port was sealed, hydration sealed, and then the opposite port was sealed. So then the results were followed after 8 months. The total number of, in the total 18 patients, the mean age was 66.02. And when we compared the mean pre-existing astigmatism, which was 1.56 to and 1.63 in the 2.4 and 3 mm group, which reduced to 1.17 and 1.01 in the post-operative group, that is a mean reduction of 0.39 and 0.62, while the higher order abrasion, they showed no significant difference. And the mean correct UCVA at 3 months also showed significant difference of 0.19 to and 0.01 in the 3 mm group, while the BCVA was 0.08 and 0.05. So what we are trying to say is that the modern cataract surgery, we are trying to go with smaller incision, foldable IOLs, and other means to correct the astigmatism. So basically to achieve post-operative emetropia and reduction of corneal astigmatism is rather important to accomplish that goal. Paired OCCIs on the steep meridian is rather a technically easy and no additional equipment requiring option. It has no significant increase in the corneal abrasion compared to the 2.4 mm OCCI, and also if we give a single incision, the abrasion did not seem to show an increase. Also in the reported cases publication, there was no increase in the post-operative endophthalmitis. So my conclusion was that OCCIs are a strong option for correcting pre-existing astigmatism in patients with corneal astigmatism less than 2 diopter, and in eyes with higher degree of astigmatism, we can either select an alternative method or a combination of both. Thank you.
Thank you, Dr. Sahil. A good presentation. The only thing that you have taken care of the pre-existing astigmatism. How about surgically induced astigmatism? Because
surgically induced astigmatism is also a concern, but like, so when we follow the usually surgically induced,
you see, you are giving incision on one side and there's incision on the opposite side. Yeah. One incision, which is the main port incision, produces some astigmatism, yes, which is known, and you are countering it by producing a same type of incision on the other side. Yes. So that will counter the surgically induced astigmatism.
Yes, sir.
Surgically induced. Now there is a pre-existing, yes, astigmatism. So what additional thing you did to correct the pre-existing astigmatism? Because this is being done, then on one side, same size of incision is given.
Yes, sir.
Same size of incision on the other side, because that will counter the surgically induced astigmatism.
So from what I have read in literature, sir, it was noted that surgically induced astigmatism at other reasons, like patient might have one steep axis, and we based on our regular surgical standards, we would give an incision.
You stress upon that you are marked.
We marked the steep axis.
Yes, you have seen, and beautifully marked. You must say that this is given in the meridian which is marked, but the incision size may change or may vary.
So,
I don't know, because it looks to be a very good studies, yes, and looks to be a very newer type of study, yes, without any single paisa to be invested more.
Yes, sir.
And does not take time. It takes hardly 30 seconds to produce another incision.
Yes, sir. So those I would say, so they were rather minor variations, because the incision itself can have like 2.4. We selected a blade that was 2.2 mm, so that 2.4 mm might be that.
You see, Sahil, I'll tell you one thing also. You see, when you make a very, very small incision, you inject and there's a stretching which occurs.
Yes.
If it is too much stretching, it produces lot of astigmatism.
Okay.
So trying to push a lens through a 2.2 I don't justify it. Until unless the incision is 2.4 or 2.8, there's no stretching. The healing process is as good as the 2.2 or 2.4.
Yes.
So, and the normal size of the IOL is folded IOL is.
So optic is 5 to 6 mm.
So it is just the double.
Yes.
Means so if you put a lens, it needs to have at least 2.4, otherwise it causes stretching of the wound.
Yes.
And stretching of the wound causes much more astigmatism than without stretching.
Dr. Jain, do you have any studies in the literature to compare your study with
So
them?
there have been many previous publications, like my seed article and like 5-6 other articles. Some of so basically the previous studies and what was different in my studies, or either they took like higher astigmatism patients and or the incision size were larger. So the healing or the final reduction was little variable. Then those had like different multiple reasons. A common consensus was that they overall led to some reduction in the net
I couldn't get to you. My submission is what the
cut off excision astigmatism क्या था? 2.5 less than that?
Sir, 2 diopter. Yes, sir.
Preoperative.
My seed article had 0.75 diopter. We selected 1 to 2 diopter and incision size we varied.
Okay. Preoperative assessment in your study and the other studies were same, or there were different parameters?
So same parameter via Scheimpflug imaging. The astigmatism was determined by the Scheimpflug imaging, not by the AR refraction. And post-operatively they were followed, and final result based on the Scheimpflug imaging, what astigmatism value it showed.
Thank you. Thank you very much.
It's a beautiful study. I must congratulate you. It's originality.
Basically, it's a good study. One thing sir is asking, or everyone is, this is a coupling incision.
Yes.
Giving neutralizing it. So again, and sir give one example of that. Ki sometimes wound size is not matter, but stretching is going.
Yes.
And perfect example of these things. Sometimes you see the femto patient femto incision made with femto and phaco done from that tight incision. So their astigmatism is 2 diopter, 3 diopter, 3, and that is very wet astigmatism. Number 3, you have put that that part is so in again for PGs you are not mentioned what is in the literature, and that comes in the dissection part in
Yes,
the
sir.
last. So in the next time when you are presenting a
Yes,
paper,
sir.
your सर ने पूछा कि कितना उसमें वो कट ऑफ था, that should be on written always. You should not.
I have that shortage
Because
of
no,
time.
this is
Yes, sir.
just try. I congratulate all because you are presenting. So we want you to see on the top. This part ROS is like doing great work and all these things.
Yes, sir.
So this is first time, and you did wonderful. I mean, no,
Thank
we
you.
are not putting your
Yes, sir. Yes.
leg some like
Yes, sir.
pulling, but thing. Number 3, pachymetry should be also there for that. How
Yes,
much
sir.
cornea before that?
Okay, sir.
Okay.
Okay, thank you, sir.
With this, we come to the end of this wonderful session of competitive papers. I compliment and congratulate all the participants for their wonderful presentation. Well done. Keep it up. And we wish you all the best for your future course. Thank you. Abhika. I request all the participants to come on the dais. We can have a group photograph.
We have to start the session now. I'll invite Chairperson Dr. Ashok Singh. Has he arrived?
He is not here, I am presiding.
So, good afternoon, Patul sir. Good afternoon, sir. So, we'll start with the
So, I think Dr. Sonu Goel has to go to other hall. So, he will want to present his case here.
I think Dr. Mukesh Sharma sir will start. And
if he is not there, then Mukesh sir, you can come.
Thank you, Chairperson sir, for allowing me to present out of the order because of engagement in Hall A. So, today I shall be presenting on IOL exchange, not a nightmare. Indications for IOL exchange are few. Sometimes there are refractive concerns, refractive surprises. We may end up with huge post-operative refractive error because of incorrect lens power. So no choice but to explant the lens. Then there may be at times with multifocal lenses, especially patients are perturbed to that extent that we need to explant these cases. But with modern generation multifocal, these indications have come down to a great extent. Then many of the time we see cases with opacification of IOL. This is a case with opaque IOL, it is appearing like a cataract. And at other times, ACIOL is creating corneal complications and all, then we need to explant it. And at times we are having IOL dislocation or dangling IOLs, things like that, then also IOL need exchange. But it's not a simple procedure. Sometimes there are risks inherited with this particular procedure. You may create general damage while removing it. There may be PCR, vitreous disturbances, there may be corneal endothelial damage, hyphema, and also incision-related issues like suture and astigmatism, though they are not very serious. And also in the back placement of second IOL may not be certain in all cases. So with this background, I will be showing you a few of the videos of IOL exchange. So this can be a varied thing. Sometimes you may have a very simple case where you need not to face any problem. This is such case. It's a case of IOL opacification. Hydrophilic acrylic IOL was there. So it could be easily taken out from the bag. So IOL is taken out of the bag. Anterior chamber is filled with dispersive viscoelastic. Then you have to counter support the IOL with your second hand. There are special forceps also available. If it is not there, you can support it with your dialer and make a nick, a cut. Just a sec, it has gone too fast. So make a nick in the optics. Now you need not to cut optics through from one end to other. Even if you cut optics till it's half, you are able to remove the IOL by just rotating the IOL. So this we have learnt now only. Previously we were cutting optics from one end to other and then removing IOL in two pieces. But now see, we have cut optic till it's half, then haptics is taken out, and then it is pulled out and rotated. You can see I am just rotating it, and IOL is coming out, and it has come down. So just by making half cut in the optic, you can take out the IOL. You can see it is a case of opaque IOL. It has been taken out, bag is there. So there was no problem in this particular case. A 3-piece IOL was implanted. Obviously the bag was not secure enough to place a single IOL in the bag. So we had to place IOL in the sulcus. So this is the completion of this particular case. Then there may be certain cases which are difficult. So this is one of those cases. This was operated, I think, 6 years down the line. Beautiful surgery was done, but the rhexis got adhered to optics all over. So I am trying to insert this straight rod underneath the rhexis margin, but the adhesion is so tight that I am not able to do it. So what we thought was to insert a 26 gauge needle, straight 26 gauge needle to obtain a cleavage plane, and I am trying to insert this inside to find a cleavage plane, and at some place I could find one, and then I am just rotating it. By doing this, we must be careful that this needle tip should not be inserted too long inside, otherwise you may be damaging the equator of that. So just insert only half of the bevel inside and separate all the adhesions all over. So this was done, and then we tried to pull out this IOL out of the bag. So optics could be taken out, but haptics, they were adhered inside, because this case was operated 5 years back. So we are trying to gently pull out this haptic, and with some manipulation we could take out this haptic. If haptic has got stuck very tightly, then you can cut the haptics like this and you can remove only optic. But with some manipulation we could take out this particular haptic. There was some general dehiscence here, but it was only 1 clock hour or so. Now we are trying it from the other side. So it has got stuck even more. So by doing that, we were seeing that granules are getting damaged. So we thought not. You can see here few of the granules, they have already broken. So what we thought then, to cut this haptic and maybe leave it there or try to remove them later on. So we had cut the haptics, this particular haptic, with the help of sharp scissors, good ones or micro scissors also. So once you have done this, then you have to cut the optic. Till this time we were not aware that we can take out IOL by rotating it and by cutting optic to just its half. So what we did was we have rotated the IOL and cut the optics end to end, and then we took out. So one piece, second piece, and the last haptic also it has come out. And again, since the bag was intact, so we could implant a 3-piece lens in the sulcus. So yet another case, it was dangling into the vitreous. So first we had to make IOL secure and we have to pull it over the iris so that it does not fall back. So we had just bought this haptics over the iris, and then the vitreous is here. So once you have secured the IOL, you have to do vitrectomy. So then the vitrectomy was done to remove the vitreous, and after completion of vitrectomy, I will be cutting this optics again in the similar fashion. So optics was cut and IOL could be removed in 2 pieces, 1 and 2, and here again the rhexis margin was there, So we could implant a 3-piece lens in the sulcus over those axis margin, and finally Kenacort was injected to look for any strand of vitreous, and few of the strands were there. They were removed at the end of surgery, and surgery was completed. So thank you, ladies and gentlemen, for your patient sharing.
Dr. Mukesh, one question. In some cases, if it is possible to, rather than IOL exchange, you can go for LASIK correction or some piggyback IOL.
Yes, sir. Those things can be done if there is some refractive surprise, and that too of not like great magnitude. If it is corrected by laser and IOL is not opaque, then one can definitely do a surface procedure over it. And I think it should be the first thing to be done in those cases. I fully agree.
And you know some in cataract and refractive there is some in hydrophilic lenses you can twisting out the lens rather than cutting that. You know the twisting out technique.
You can?
Twisting out technique.
Again, that twisting out can be done, but if opaque lens is there, then ultimately you need to remove.
Yeah, definitely. Yes.
Yes. So the precaution is one, to always check for endothelial count before the surgery. Even if you are not having it, get it done from any other place. You have to have a safe endothelial count to work. Otherwise, if patient develops post-op bullous keratopathy, then you will have it. So first thing is to have endothelial count done, and then to have a proper cushion to the endothelium. So Viscot is a kind of necessity in these cases. Always fill your anterior chamber multiple times during your surgery. Keep on filling it and doing your maneuvering, because the anterior chamber should not be shallow at any point, and your endothelial cushion should always be there.
Okay, thank you.
And one other thing is, if you are not able to remove IOL in toto, some part of haptic is there, leave it there only. It will not create any problem. You can push in 3-piece lens with the haptics of 3-piece align at other axis than the left part of old IOL.
So rather than damaging the jonules, it's better to cut the haptics inside and then remove the only optic part, and then IOL exchange can be done.
So,
okay.
Now, thank you, sir.
Thank you.
Now I invite Dr. Ashok Meena sir for his talk.
I can invite Ashok. You can come to this as a panelist. You can come. Sudhir ji, sir. In place of Ashok ji, you can come.
So, good afternoon, everybody. I thank to ROS team who give me opportunity for the presentations. Today I am presenting tips for the retrocapillary iris claw IOL implantations. Basically, aphakia management as a consequence of complicated cataract surgery is difficult for the cataract surgeons. Due to insufficiency posterior capsular or there is a weak ciliary zonule support, it is very difficult to implant the conventional posterior IOL. So, secondary IOL implantation including the AC IOL, scleral fixation IOL or iris claw IOL is the opportunity or alternative to the PC IOL. Retrocapillary iris claw lens implantation is a surgical procedure that involves the implantation of an iris claw lens behind the iris by using the two small clips that grabs the iris tissue. Nowadays, this technique gained popularity in recent years, and it is a viable option for the patients with the insufficient capsular support due to their simple and fast technique and favorable functional outcome and safety point of view. Why we go toward the retrocapillary iris claw lens than the other secondary IOLs? AC IOL. AC IOL is the various drawbacks due to the size. If there is a small size of the AC IOL, it causes the rotational or dislocation, increasing the risk of the corneal endothelial damage or maybe angle damage. So cornea become decompensated. If there is a large size of the IOL, it can cause the peripheral enterocyania and cause the secondary glaucoma. So due to incorrect size of the ACIOL, it can result the UGS syndrome. Sclerofacial IOL is a good alternative for the aphakic correction. It has a major advantage like the more biological location in the eye closer to the plane of the crystal lens away from the cornea, so which decrease the risk of the corneal endothelial damage. The primary drawback of the sclerofacial IOL is that it is patient surgeon require the high skill. So generally, a sclerofacial IOL done by the vitreoretinal surgeon or require the more surgical skill. Other complication of the sclerofacial IOL is due to transscleral sutures or suture-related problems, haptic extrusions, retinal detachment, suprachoroidal detachment, or there may be endophthalmitis. There are various indications of the iris flow lens, senile cataract with severe genuine dialysis, developmental cataract with subluxation of the extraocular lenses, traumatic cataracts with jaundice weak, patient plan with the PKP or maybe pseudo exfoliation. Secondary indication, aphakia associated with the surgical complication or there may be traumatic aphakia. The lens may be designed according to either we can fix in the ACIOL antechamber or the behind the PC fixation. The optical diameter average 5.4 mm and overall diameter of this lens is 8.5 mm. And the eye will be fixed in the mid periphery of the iris stroma. So the pupillary area will be normal function, dilated and fixation will not disturb. In pediatric, the size of the lens will be slightly smaller. And a question will depend upon the what technique will be used for the IOL calculations. This will be available in the various +2 diopter to +30 diopter. Before we plan the iris flow lens, we are thoroughly pre-operative evaluation very important. Complete history of the patient, especially any past ocular trauma, any surgical history or any medical history will be very important. And we compensatory ocular examination, anterior as well as the posterior segment to rule out any comorbidity that may interfere the post-operative outcomes. Iris must have sufficient support for the implantation of the retropupillary iris claw lens. How you plan for the retropupillary iris claw lens? Surgeon will go through the local anesthesia. Either we can use the retrobulbar or the peribulbar or maybe subtenonal anesthesia. First we do the 5.5 supraoscular corneal tunnel or maybe clear corneal incisions along with 2 paracenteres at the 3 o'clock and 9 o'clock will be planned. After this, we are using the antechamber maintenance should be used to maintain the antechamber, and antevitrectomy if required we can go, and then we go pilocarpine to people will be round regular, and then we find out if there are any vitreous we can cut with the antevitrectomy, and then we viscoelastic substitute inject to maintain the antechambers. After that, iris flow lens will be grafted by using the special lens holding forceps and introduced in the antechamber. After that, we rotate the haptics of the lens at the 3 o'clock and 9 o'clock in the position at the enclavation sides. So the eye will be rotated in such a way that the haptics are in line with the enclavation sides. After that, a Sinskey hook pass through the side port at the 3 o'clock. Then haptic and the enclavation side is gently tilted upward behind the iris to produce an intent on the iris while holding the optics with the lens forceps. Then the iris is enclaved into the haptics claw with the gently pushed by using the Sinskey hook. Similar maneuver is done through the other side ports. Then gently grip of the optical hold will be released and see the stability of the iris claw lens. See the postoperative picture of the iris claw lens. What are the postoperative complications? There may be disenclavation of the one or both sides. Sometimes there is ovulation. There may be pigmentation dysplasia, or sometimes there may be cystoid macular edema. The contraindication: chronic inflamed eyes, chronic uncontrolled glaucoma, any corneal decomposition condition, severe iris atrophy, any retinal pathology, any chronic infection. These are the contraindications. So the message is the retropupillary iris claw lens is viable option for management of the aphakia in complicated cases. and the complication associated with the retropupillary iris flow lens implant is minimal as compared to the benefit. So it is a less invasive and low learning curve as compared to the scalar fixation IOL. So it is a alternative to the scalar fixation IOL. Good as compared to the scalar fixation IOL. Thank you.
I think peripheral iridectomy should be done in every cases wherever possible. And one more thing, that proper scleral tunnel should be made instead of clear corneal, as you said. I think scleral tunnel will give a better control of the eye.
Any sort of pre-op workup, extra workup you do in these cases?
Pre-op, we are doing the anterior segment as the posterior segment, examinations, and along with the iris condition will be very important. So when we are using the iris, we fix the lens, so iris will be healthy. Some point where you fix the iris, if there is stroma not healthy, it will be dislocation or there may be tilting. So there may be patient may be astigmatic or some other problems will be there. So iris condition will be also good before you plan for the iris flow lens.
So, do you have any formula for the what formula are you using for calculation, power calculation?
IOL calculation.
Power calculation, yes.
IOL calculation formula same, but we first change the A constant will be different. Whether you fix the retropupillary or the iris fixation.
Any sort of formula you advocate in these cases, or aphakic mode? You do it in aphakic mode. Ultrasonic you are using, or just?
We are using ultrasonic.
Very nice talk, sir. Thank you.
Very nice talk. Now I am inviting. Yeah. So I am inviting Dr. Bagla sir. Please give this certificate to Dr. Ashok. So now I am inviting very prolific surgeon, and no required any introduction for Dr. Sonu Goel. He will speak about managing complex situations.
So very good afternoon, and thank you Dr. Atul Tyagi, Dr. Ankur, Dr. Subir Singh, and dignitaries of the dais. So another 8 minutes, I'm just talking on managing complex. I'll be talking on managing complex sublux scenarios. So I think the whole gist of my talk lies on this wonderful presentation, publication in the JCRS, which was published by Hoffman and Uday Devgan, and these are the authorities for management of challenging subluxuric cataracts worldwide. And the whole conclusion of this paper was to achieve, when you're dealing with subluxuric cataracts, the aim is to achieve a successful in-the-bag placement and centration of the intraocular lenses and reducing the complications. So, when a patient with subluxation comes to us, I think what is more important is to have extensive slit-lamp examination where you are trying to ascertain what is the degree of subluxation, varying from mild, moderate, severe, So when the lens edge uncovers 0 to 25% of dilated pupil, you call it mild, 25 to 50% is moderate, more than 50% is called severe. Apart from this, what you need to ascertain is the degree of zonular loss or the zonular status, and this is only once you take the patient after full dilatation on the slit lamp examination. You have to look in whether the zonular loss is just localized, which is usually caused by focal trauma or congenital defects, or it could be extensive, as you find in Marfan's or pseudoexfoliation. The lens edge is very important because it could be flat or rounded. So if you have flat edge, that means the rest of the zonular fibers are healthy, or if it is rounded, that means the unhealthy adjacent zonules could be found out. So detailed examination and UBM examination is a must, and the patient should be examined both in the supine and the lying position, because at times what you see on the slit lamp in sitting position, the lens in the place, but the moment you make the patient lie down, the lens might you might see that the lens is freely floating within the vitreous cavity, or at times to be surprised, there is no lens in the place. Now, the choice of capsular support, I would always recommend in your OR, you should have all of these, because you never know what circumstances you're going to face. So these are the capsular tension rings, the hammer segments, these are the capsular hooks, and these are modified CTR rings. Now that depends on the degree of zonular lysis, whether it is progressive or static, and what is the strength of zonules. You can use either a capsular tension ring here, you can use a Cioni CTR, you can use an Ahmed segment here, you can have the ASI-anchor device, the Yagachaki hook, or the capsular hooks. I think the whole armamentarium should be there in the OR to look in for any kind of surprises. So you can have hooks. There are iris versus capsular supports. So this is what is called the iris hooks, and this is only in non-dilating pupils. But whenever you are using capsular hooks, this is to support the capsular ring that you have created after doing the capsular excess. Now, my decision algorithm for subluxated cataract is usually when you have a zonal lysis between 3 to 4 clock hours, I would just push in a capsular tension ring, that is a single point support. But when you have between 4 to 8 clock hours, either you do a Cioni 1L, that means you have to have a single point of fixation. So you put a capsular tension segment, that is an Ahmed segment, you tie it and put in a capsular tension ring. But when you have more than 8 clock hours, you actually need a CTR with 2 CTS, 2 capsular tension segments, or 2 point fixation is what is required in these patients. Always it should be try pushing clockwise the capsular tension ring, and it should always be directed towards the area of maximum zonal lysis. The suture material, we have all been using this ninoprolene over years, but we have found that the nino or the tenoprolene hydrolyzes over 5 to 10 years. So over 20 years of the cases that we've been doing, we found out that over 5 to 10 years, the patient comes up back with the subluxated lenses. So now we have shifted to what is called as the CV8 or the Gore-Tex, and I'll just share what the lasso technique that we use in dealing with these subluxated patients. So here, if you see, this is one of the pictures of the lens being subluxated, a good viscoelastic being pushed in, and what is more important is to create a central capsular axis, leaving a small rim here. You should not reach the periphery, because this is the point which actually will be required to give your capsular hook support. Use of microrhexis forceps from the side port is a great idea because it prevents the chamber from shallowing. And once you have achieved a rhexis, I think that is very, very important. A gentle hydro dissection, and since it's a very, very soft lens, you can easily aspirate. Your parameters should usually be very low. And watch my left hand, because this left hand, the irrigation is always inside the bag. I'm trying to push the fluid inside the bag so that it prevents the vitreous from hydrating. At the same time, keeps the bag distended. So just watch carefully. I have eaten up, but my right hand pushes the viscoelastic because I don't want the chamber to shallow. The moment the chamber shallow, the vitreous might come anteriorly and you might have more of subluxation. So I make a 2.4 main port entry, again distend the bag, and this is the time when the ring goes in. Just mark, it's a preloaded capsular tension ring and it is towards the area of subluxation. The ring once goes and sits, now you have a distended bag. Now this is what I'm trying to create, a Hoffman pocket. This is, I'll just take one more minute. And this Hoffman pocket is actually what is required for transfixation of these lenses. So this is I mark 1.5 behind the limbus. This is the Ahmed segment, and this is the 8O Gore-Tex suture, which is threaded inside the Ahmed segment. And now what is important is to externalize these two ends of the Gore-Tex outside this Hoffman pocket that we have created. So just watch carefully. I have threaded this 8O Gore-Tex inside a 26 gauge needle. So I have created a loop. Now this loop basically helps in externalizing the either ends of the threads of the Ahmed segment. So this one end of the Ahmed segment is looped inside, and I gradually withdraw this loop through the transscleral groove through the Hoffman pocket. Now the loop goes in, and through the loop I will thread the other end of the Ahmed segment here and then gradually withdraw. So now my aim is achieved. Both the ends are externalized, and now I'll gradually push this Ahmed segment inside the anterior chamber. The moment this goes in, I would push this inside the bag. Watch carefully, the bag always has to be distended with viscoelastic, and now you gradually withdraw this 8O Gore-Tex through the main wound. So watch carefully, and the bag starts centralizing. Now you can use this Coughlin to withdraw the 8O Gore-Tex from the Hoffman pocket, because you just want the suture material to be within the pocket under the sclera. It is not externalized, because the moment the Gore-Tex is externalized, it causes rubbing, and then it might cause some inflammation in the anterior chamber. So I have withdrawn this, and purposefully I have chosen a 3-piece lens here, because at times the bag might give way. So I might convert this into a Yamane technique or a glued IOL just in case my bag gives way. So very gently I am trying to snug the lens inside the bag with the 3-piece lens going, and you achieve a very stable lens inside the bag. Now is the time. Looking into the 3 Purkinje images of my Lumira microscope, I was trying to centralize this whole lens bag complex. So just watch carefully. This is one suture. I put a 1 knot and just try to fix it in a way that the Purkinje images become quite central. So 1, 2, 3 is the knots. It's trimmed, and then this can be pushed underneath the Hoffman pocket, and that is what is achieved in these complex lens scenarios. A good viscoelastic wash is required. At times, if you feel there is vitreous, you can do a triamcinolone, do a limited anterior vitrectomy, hydrate the wounds, and you can achieve a good centered lens bag complex in most of these patients. So viscoelastic is a must, because this is the day 1 picture of these patients, and there is hardly any telltale sign around the sclera for these transfixations. So thank you very much.
Thank you. Excellent surgery shown by Dr. Sonu. One question from for the what is this Gore-Tex suture? This 8O Gore-Tex suture. It is, I think, very costly suture. It costs around 70,000 per box, if I am not wrong.
So the way to procure this is from your pediatric cardiologist, who routinely use in their pediatric cardiological surgeries, and it hardly costs around 700 for a single foil, and maybe 4,000 or 5,000 rupees for a box of Gore-Tex. And believe me, this technique is very easy to practice, and we've learned, and actually it gives you a lot of good results, and it's easily reproducible.
Okay.
Excellent talk, sir. What are the suggestions for the new surgeons in this regard?
So I think my aim of this talk was to highlight that in wherever we are dealing in cataract surgery, a lot of pseudo-exfoliation patients that we encounter, we all should have an access to a capsular tension ring. And nowadays, Madhu instrument, no proprietary test, they have preloaded CTR rings available with them, and they are hardly any cost. So routinely you should all practice pushing the CTRs in these patients wherever you feel it's a hypermature Morganian loose bag, it's a pseudo-exfoliation bag, or wherever during irrigation aspiration you feel that there is some amount of zonal dialysis. I think capsular tension ring injection is a great aid to managing these cases.
Yes, sir. Thank you, sir.
Thank you.
So I am Dr. Sonu. Please take that certificate. Please, Ankur, please give the certificate to Dr. Sonu Goyal. So now I am inviting Dr. Chaitanya Gupta for his topic IOL power calculation in special cases.
Good afternoon, everyone. Since cataract surgery is nowadays also a part of refractive surgery, so it becomes much essential to precise biometry before surgery. Earlier, fixed IOL power was being used to implant, but that gave a very refractive surfaces. So our aim is to achieve the emmetropia or slight degree of myopia as required. IOL power calculation errors can arise from the keratometry, axial length, a constant, though it is constant, but it is variable depending on IOL type, material and surgeon dependent also, and different IOL formula also can give rise to error in your IOL power calculation. Keratometry used to measure the corneal curvature and dioptric power. There are types of keratometers: manual, automated, incorporated in IOL masters, and topography also used for the keratometry. Manual keratometry wash and round measure the radius of curvature of anterior corneal surface only and convert it into the corneal power, and it measure the larger zone away from the center around 3.5 millimeter, but it has limited value in post-RK and post-cataract surgery patients. Automated keratometers are available to focus the reflected corneal image on an electronic photosensitive device, which instantly record the size and compute the radius of curvature, and it measures the central 3 millimeter zone, and it is better than manual keratometry in terms of zone measures. IOL masters again have incorporated the keratometry, and the number of point tested 6 in a diameter of 2.3 millimeter zone in hexagonal pattern. While a lens star measured the 32 points in two circles of 1.65 millimeter and 2.3 millimeter. Then by topography we can calculate the keratometry. Simulated K is available. Estimated K reading is determined by adding 0.7 diopter to total corneal refractive power and measure the total corneal refractive power. And greatest central K on topo. Standard keratometry tends to overestimate the corneal curvature and we accept a hyperopic shift post-RK. So flattest central K is the used for the IOL power calculation in post-RK patients. Next is the axial length measurement, which is the most important part. 1 millimeter of error lead to 2.5 diopter error in the calculation, and there are types to measure it: optical and ultrasound. In ultrasound, again, it is contact method and immersion method. It measures the length of the from anterior corneal surface to internal emitting membrane. One thin parallel sound beam is emitted from the probe of the 10 MHz frequency, with echo bouncing onto the probe tip as the sound beam strike each interface. There are in the change in gain when the situation is different. You can increase the gain when the height of echo is achieved is inadequate, as in dense cataract, and you can decrease the gain like in silicon filled eye or pseudophakic eye. There is another method of A-scan is the immersion method, which is more accurate than contact method as the corneal compression is avoided, but it has also limitations in accurate readings in silicon filled eye and posterior stephyloma. Then come the roles of optical biometry, which is highly accurate, measure the anatomical details of the eye. Different principles are partial coherence interferometry, optical low coherence spectrometry, swept source, and it measures the distance from corneal apex to RPE, and more precise calculations are there, especially useful in stephyloma or silicon filled eye, and also in more useful in premium IOLs. There are different IOL formulas which can be used wisely in different conditions. If the eye is short, Volade 2 or Operq is more accurate. In normal axial length patient, which is 20 to 24.5 millimeter, SRKT and Volade gives the good biometry. And in long axial wall, again SRKT and Volade 1. In nanophthalmos eye, Operq and Agis formula, and post-refractive surgery, topography with true net K and flattest K with formula according to Excellent. Samaj formula can be used in these eyes. In specific conditions, in aphakic eye, 2 lens spike are replaced by single spike. So emergent technique is better in aphakic eyes. In present biometers, aphakic mode is available, and in ACIO or still fit diode, the appropriate A constant is used. In keratoconus eye, again the K reading gives the error. So we use the formula which at the less effect of keratometry, like Hopper Q and Huggies. In silicon field or vitrectomy eye, the refractive index is much less than, so the usual A scan gives the incorrect readings up to 8 millimeter. So we can increase the system gain in our A scans, or we can use the IO master which gives the better A scan readings in these cases. In high myopia cases, again there is accurate axial measurement is critical. So most of these errors can be deleted by the using IO master 700 by directly visualizing the fovea on OCT images. In pediatric biometry, again it is a very difficult part to implant the correct power. So under correction of 60 to 75% is recommended. In piggyback IOL, Huggies or Hopper Q formula can be used. Secondary IOL Holaday refractive formula. And in LASIK cases, I told already, there is 2 K value is used. We have studied our 100 patients, use the different method, contact and immersion, and 2 formulas were used, SRKT and Holaday. On our conclusion was there was significant difference in ocular biometry measurement with contact and immersion method. The immersion technique had better repeatability, thus it is ideal in training hospital settings. Immersion avoids the corneal compression but has less control over alignment, so it can give rise varied results, and the combination of technique can give the better results. Take home message: use appropriate formula according to patient eye status. Not a single formula is good in all cases, and use better technique. The emergent technique, which is neither expensive nor difficult, can easily be done in OPD settings. Good. Thanks.
So one question from you: if patient is having RK or post LASIK ablations in these cases, what is your advice?
Sir, in these cases, if you implant the IOL, if the myopic refractive surgery is done, there is a hyperopic surprise. While in hyperopic LASIK, there are myopic surprise.
Yeah.
So we have to take the flattest K, either by the pentacams, or if we have previous records available, then can be do that.
So in LASIK surgery, it's not flattest K. In LASIK surgery, the anterior part and posterior part curvature, that is the ratio which is called Gulstrand ratio. That ratio is changed. So we can't measure the posterior corneal curvature, and in an anterior keratometry only can measure the peripheral 3.5 millimeter. Central part we cannot measure.
Yes,
So because the maximum changes occur in the central part, flattening in LASIK is occur in central part. So what we can do is we can do total cornea TK. TK is available in Lenstar 700. So we can use formula which is called Barrett universal formula with TK formula. That is, and second, if you don't have that form also available, then we can use ESCS or Esker's formula. We can go to that site and we can use post LASIK formula. You can give all the measurement. Basically, problem with post LASIK is that there is change in the effective lens position.
Yes, sir. I told this.
Yes.
In LASIK and post-RK patients, you can have topography image, a pentagram image, and then combined keratometry, and then doing a good immersion biometry will be helpful, and then you can use an ECRS website formula. This gives excellent results, and you can plan toric also in these cases. But the bottom line is all the investigations should be done by the surgeon himself in these cases, and we should not rely on the staff for this.
I think if we don't have access to optical biometer, roughly what we can do, what the IOL power comes, we can add 1/3 of the refractive error into that, and almost it works.
And, are there any limitations of optical biometer? Are they 100% correct?
No, sir.
So basically, again, these are the things. So you should always explain to your patient there may be some, and if surprise is going to happen, and it should be myopic. So that should be your aim. एंड पालीवाल जी, ये पड़ोसी वाले बहुत बवाल मचा रखे हैं, थोड़ा सा कम चलाएं, यहाँ पे डिस्टर्बेंस हो रहा है बच्चों को पढ़ाई में.
So I invite Dr. Sudhir Singh to give this certificate to Chetan.
Now we invite Dr. Lipi Mittal for.
Very nice presentation. Yes, Chetan ji. Lipi Mittal, she is available. Oh.
Good afternoon, everyone. Thank you, RAS, for providing me this opportunity. I will be speaking about posterior polar cataract. PPC is a round, discoid, opaque mass which is located in the central posterior lenticonus region. It is bilateral in 65 to 80% cases without any gender predilection. It is usually autosomal dominant. Oh, it is moving here.
Okay.
It is usually autosomal dominant, occasionally sporadic, with many gene mutations, commonly being alpha-D-cysteine and PITX3. Due to vacuole-like changes in the vicinity of the central opacity, patient can experience intolerance to light, glare, decreased visual acuity, and reduced contrast sensitivity. There are a number of classifications for better understanding of PPC. One of them is given by Dr. Daljit Singh. Type 1 is associated with posterior subcapsular cataract. Type 2 is a round, well-defined opacity with onion ring appearance. Type 3 is round opacity with dense white spots at the edges. And type 4 is associated with nuclear sclerosis. Preoperative counseling of the patient is of utmost importance, where we should counsel the patient about the chances of nucleus drop, relative long duration of surgery, chances of delayed visual recovery, and need for secondary intervention in terms of secondary eye implantation if required, need for posterior segment intervention, and need for NDR capsulotomy later. Continuous curvilinear capsulorhexis is mandatory in every case, and we should avoid anterior chamber fluctuation. Low flow phaco emulsification parameters should be used in such cases. Hydro procedures, cortical cleaning hydrodissection should be avoided. Hydrodelineation is imperative, and one of the technique is inside-out delineation, which has been given by Dr. Vasavda, in which a trench is sculpted and the fluid is directed into the lens fiber through one of the trench wall for the hydrodelineation. Golden ring formation is an indicator of successful delineation. This is a video to show a successful hydrodelineation. This is a short clip in which there is construction of continuous curvilinear capsulorhexis of around 5 mm.
देखना भाई.
Audiovisual.
कर रहे हैं.
Construction of continuous curvilinear capsulorhexis of adequate size is very important in such cases. Too large rhexis will not allow IOL implantation into sulcus if required, and too small rhexis will increase the hydraulic pressure and can lead to difficulty in epinuclear and cortical plate removal. So golden ring formation is an important sign and it indicates successful hydrodelineation. There are multiple nucleotomy techniques. like phacoaspiration for softer cataracts, phaco-chop technique. Lee et al. Described one lambda technique in which the nucleus is sculpted in the shape of lambda and it is followed by crack along one of the arms. Another is reverse bloom technique in which after nucleus is emulsified, cortical removal is done from outside to inside, leaving the central portion intact, which is removed in the later half, and it resembles reverse blooming of a flower. So here the cortical matter is removed from outside to inside, and at last the central portion is taken up, just like reverse blooming of the flower. For epinucleus and cortical removal by viscodissection is the preferred technique. Sometimes after removal of the posterior polar opacity, onion ring appearance is seen, but since the posterior capsule is intact in such cases, it is known as a pseudo-hole sign. Dr. Vajpayee et al. Described layer-by-layer technique for epinucleus removal, in which layer-by-layer emulsification and aspiration of the epinucleus and cortical matter is done. If there is a posterior capsule rupture and if it is without vitreous prolapse, first we should use a viscodispersive material before withdrawal of the handpiece to maintain the chamber. Try to convert the tear to continuous curvilinear capsulorhexis if possible and assess the size of PCR. If it is small, IOL can be put in the back. If it is a large PCR or an irregular PCR, sulcus multi-piece IOL should be implanted in sulcus. If it is associated with vitreous prolapse, anterior vitrectomy should be done, followed by the same algorithm. And if it is associated with nucleus or cortical dropping, we should call our vitreoretinal colleague for intervention. So take-home points are adequate size capsulorhexis, avoid cortical cleaning hydrodissection, gentle hydrodelineation, maintaining a stable chamber, low phacoemulsification parameter should be used, gentle nucleus handling, and tackling the central epinuclear plate in the last part of the cortical cleaning. Thank you.
Thank you for the excellent talk. We covered all the points already. Any personal advice for that?
I am myself a beginner with phaco. I am also a new surgeon.
So this talk would be complete since I am going to talk on same topic. So whether I can start right now or later on?
Yes, sir.
Huh? Okay, it's fine. So it will be good for teaching. Many part of this talk is covered beautifully by Dr. Preeti. And she has the audacity to speaking on the posterior polar cataract.
चल बाद में दे देंगे बाद में दे देंगे बाद में. So I am inviting Dr. Ankur Midha to give this certificate to Lipi Mittal.
So very good afternoon, and posterior polar is very complex topic, but I love to speak on this topic. Although 6 minutes is very less to just for teaching or just to make understand things properly, but I'll try to make things clear in 6 minutes, few parts. So I'll take a holistic approach, means I'll touch both the techniques, basically phaco and SICS and other things also. This is the posterior polar cataract, you can see it. The classification part is very well touched by Dr. Lipi. And why we should have a rhexis, it should be 5 to 6 millimeter. In case if there is a PCR or something like so, we can rest IOL beautifully in the sulcus. And this is like a 5.5 or 6 millimeter rhexis. Can be done by needle. You don't need any. Now people are promoting we require a machine of multi-carot. Not required. You can do it. My opinion, understanding of posterior polar cataract, we can do the hydrodissection and hydrodelineation if it done properly and the proper plane. Because ultimately we are going to separate posterior polar cataract from the posterior capsule only by
hydrodissection. So this is thing. I mean, as I said, we are just this nucleus was separated and taken out with the vectors or phaco. So if you have done this step, then you are sure that your nucleus is not going to be a drop, and you can manage all the thing. Now, see carefully this. This is using hydrocannula and separating the this plate from very gently, pressing posterior lip, and it requires a lot of manipulation on that. Now I'll do the visco separation. You can see beautifully. This is visco separation. I'm trying to separate posterior obesity with posterior capsule. It's a very gentle and it's a very reproducible. So I'm working on the inventory of many videos. So now this is, now you can see this is beautifully separated without anything. I'm playing with this opacity. It's yeah. Meanwhile, for posterior polar cataract, your vitrectomy machine should be ready. Now it's almost done. Now IA you can do whatever method, but it should be gentle and maybe bimanual, or maybe I usually prefer by side port, use cannula, and this can be done easily. So posterior polar cataract can be done easily without any problem. If anything happens, then your vitrectomy machine and cutter should be ready in your OT beforehand, and that is the must. Now this is second thing. If you are going to do the phaco, then again I do the hydrodissection and I do the hydrodelineation, and I take out the risk because I take out the nucleus from the bag, and then I just as you can see, just is coming out. Because this is the lab. If you are doing the SICS, then you are playing with the nucleus so many times, so that it's not big thing. Easily come out and separated from the posterior polar opacity. Now this is safer place, and the lower parameter you can do the phaco. Because in the femto, people are doing same thing. They are dicing the nucleus and they are taking out. Now at this place, you are safe that you are not going to drop the nucleus. You can say it's lollipop technique or whatever technique. Just you need to take nucleus out. And this can come easily. A very minimum amount of energy is required in this, and so in this posterior polar cataract, what is required is the patience, and your AC should be stable, and so one thing, in case of rent, then I prefer the PMMA lenses, and this is the PMMA lenses, big optics and haptics. So this should be first your leading or haptics should be touch on the periphery and then gently dilate. So vitrectomy parties I have not touched because cannot be covered in this, and after this again retro-IOL cleanup is very important. So I'm showing this is a little clip. You can go behind the lens and clean all the vitreous and or material. That is very important. Otherwise, it will lead to inflammation. And just 30 seconds. 30 seconds. This is slow. Now we can check it with the Triamcinolone. If there is any remnant of vitreous is there or strand is there, we can cut it. So because for the attempting the posterior polar, you should well versed with the enterovitrectomy and with normal phaco machines. These are there, and this is okay. And I would was 30-second. Why I use this progressive technique for the phaco? I want to show the 30-second clip more. So I need 30-second more, just 30-second. Oh, so this is for very important for the beginners. This is a phaco. When we are doing this, and sometimes what is going to do, because these are soft carotid, sticky carotid, so they're not coming. See, what was this is snap sign. Snap sign. So what this? I touch the posterior capillus and that drop the nucleus. So thank you very much for giving me the report time with the Palivalji. Palivalji is my batchmate, parallel batchmate, and he is the host. So I am the guest. So I can take this privilege. Thank you.
So few things I also add. This PC posterior capsule absent only in 23% cases. In posterior polar cataract, only in 23% cases the posterior capsule is absent, and he may be successful because phaco is a closed chamber technique. So pressure is all around. You can't withdraw. While in case of SICS, pressure is relatively distributed. So it may be possible that in SICS, PC chances are less. But the third thing that I have to mention is that during the epinucleus removal, there is this PC rupture will there. There is no rupture during the nucleus removal. So you should always pay attention during the epinucleus removal. At that time, rupture will occur. And third thing is that visco should be used rather than using the water for the hydrodissection. Rather than using the saline, it's better to use visco during the separation of the capsule from the epinucleus. Thank you. Yes.
The rotation of nucleus during phaco in PPG case is very dangerous. If PCR happen, definitely it will happen if we are rotating the nucleus.
No, there are so many myths, and I have series of videos, and okay, so you can easily rotate nucleus because nucleus is away from that. You are not rotating the epinucleus. You are rotating the nucleus.
Hydrodissection is not to be done.
So this is a very important part. You can easily rotate and play with nucleus. Nothing in posterior polar is the safest cataract you see otherwise.
He is rotating the endonucleus, not the nucleus. Nucleus means epinucleus plus. He was rotating the endonuclear part only.
The hydrodissection previously in that case.
Anything want to add, Menk?
And one thing more, sir. One thing. If there is a PCR, it's going to happen there. Okay, so you are ready. Your nucleus should not be dropped. Okay, cortical matter doesn't matter come out.
Sir, I would like to add few things that nucleus rotation, yes, you are able to do it, but rather it should be avoided as far as possible. What I do is do a mechanical separation after doing a hydrodelineation, mild hydrodelineation, or you do hydro at multiple places in hydrodelineation and mechanically separate it like Dr. Sudhir did, and then take it a little into the AC and then you can eat out. That is easy. But the complete nucleus rotation as we do in our routine phacoemulsification cases should be really avoided because it produces a lot of pressure on the posterior capsule as well. Second thing is the parameter should be low. I would really like to add one thing that I usually make a slightly oval shaped axis in all my posterior polar, because in case there is a PC rupture and I have to put the lens so that I can tuck it with the capsule. So I will always make a little oval, a little smaller like 5 mm axis. That is my intention is on my posterior polar cases.
Because most of cataracts are like soft captures, so that is fine.
Yeah.
Okay.
So I am inviting Ankur. Please give the certificate to Sudhir.
Paliwal sir for his talk.
सही बात है, मुझे पता है।
क्या हो गया कि सबको बिठाना है, सबको करना है, टीचिंग होती है।
Yes, go ahead.
Very good afternoon to all of you. Thank you, Chairperson. Thank you, Arus, for giving me the opportunity. My topic is unorthodox way of nucleus management in heart cataract. As we all know, heart, in spite of having best of technology in phaco machines, heart cataract management is still not very easy. Heart cataract management is difficult. Why it is difficult? It is difficult because density of lens is very hard. It is less compressible. Its the lens fibers are leathery. There is very less cortical cushion or totally absent cushion. There are different techniques available. There are different techniques followed by different surgeons. I will not go into the details of these techniques. Crater and chop technique is the most widely used technique, and a multi-level chop technique devised by Dr. Pasauda sir. I do my heart cataract in different way. Before explaining my technique, we would like to discuss the anatomy of the nucleus. As you all know, central nucleus is the hardest. Then there are layers. Layers are in concentric form, and each layers are having a natural cleavage. So layers can be separated, but fibers are there adherent, and they are hard and adherent. So it is difficult to separate the fibers, but it is easy to separate the layers. And this is the natural anatomy, which I will take the advantage of this anatomy in my technique. So my strategy is not to target the complete separation. As we all know, cataract is hard, so there is less space. Antechamber is shallow. Peripheral, the nucleus fibers are tightly adherent. So we do peripheral superficial chops, and we would like to delineate the central nucleus. First we delineate by making multiple chops in the periphery, then disengage the central nucleus, create the space, then we manage the mid and outer layer. I will show this in my video. This is the first case. First two cases I will show you how to delineate and disengage the nucleus. These are the peripheral chops which I am making after making initial central crater. Peripheral superficial to mid depth chops are made. Once the periphery or once the margin of nucleus is visible, central core is visible, we keep on doing separation till all the nucleus is free. Now you can see nucleus is free and it's being emulsified. Now we have the space for maneuverability. So now this is the second case with lesser degree of the hardness. Same technique, same superficial chops, peripheral chops, delineating the nucleus by separating along 360 degree of its circumference. Once it is totally delineated, it is disengaged. Now nucleus is disengaged and now it is being emulsified. There is central space. Now this is the third case. In this I will show you complete technique. Initial superficial peripheral chops, aiming delineation of the nucleus, central nucleus. Once it is delineated, it is emulsified. Now it is disengaged, then is being emulsified. Now I will be managing the rest of the stuff. Because this cataract is not so hard, So in one go or in one step, making smaller chops, peripheral chops, the emulsification can be done. Idea is to make smallest possible pieces, because if you emulsify larger piece, there are chances of chattering and making many smaller pieces that may go behind the iris and can create problem in the we can miss it and they come in the large. So it's better to make smaller possible pieces. So this is what I am exactly doing, making smaller pieces and then emulsifying. So nucleus gone, peripheral part is being managed, and this is around grade 4 cataract. So by doing this technique is managing very easily. The one thing which I told previously, when cataract is hard, we can remove the cataract in the 3 stages. First, central removal of the nucleus, then mid part is removed, and in the last, peripheral part is removed. Now I am showing that this technique, central part has been removed. Now the mid part, because I said the layers they are not adherent, they can be removed very easily. So we are removing the middle part. Middle part, and with the Sinskey, we are supporting the peripheral part and not allowing the part to come in the center. You can see with the Sinskey carefully. So we are keeping the peripheral part at its place, not allowing to come in the center part, and middle part is being held properly and being emulsified. And by doing this, in the last we will have a plate, and which can be removed in single go very easily. This is how we are removing the middle part. There is a peripheral plate or a plate which is protecting the posterior capsule, and we are in that way we are safe, and we need not to laterally separate. We don't require much power. Now this is the last plate which is being removed very easily, and this can be removed in one go. So this is my technique. So in conclusion, the phacoemulsification in hard cataract is challenging, and the best technique for the phaco surgeon is the right balance in the ease of performing surgery as well as repeatability of the procedure. And this technique I discussed has both. I have shown the 3 to 4 cases with the different grades of nucleus. Thank you very much.
So very beautifully shown by Mahendraji that how you can remove these type of lenses. If the hard cataract have a leathery posterior capsule, leathery posterior part, then you can't remove the part and divide that nucleus into 2 parts. Then this is what you call a flower petal technique, in which you are doing superficial nucleotomies, and central nuclear endonuclear part is the most hardest part that you can remove, and then you remove the petals and then left the central disc type of a part, then you can easily remove. So initially, if it's you can't separate the nucleus, divide the nucleus in 2 parts, then this is very good technique for beginners. It's very good. Thank you.
These were very good. This was very good demonstration of hard cataracts. You have done a commendable job. Thank you. Take home message is be patient with these cases. Do it slowly. Use a lot of viscoelastic, and peripheral nucleotomies help a lot in these cases.
One thing more about this technique, beautifully shown 3-4 cases, and surgeon seems to be no in hurry. That is very important. And some people as being heroic, I can do the direct chop and all. So in the all 3-4 cases, the minimal stress of zonules were there. There were no stress of there. So what even is good for every surgeon, the technique. So wonderfully present, Paliwal ji.
Thank you, sir.
So please take the certificate from Dr. Sudhir Singh. He is your class fellow, sir. Yeah.
Parallel batch ke hain.
We'll invite Dr. Surbi Khandekar.
chamber anatomy. So basically, whenever you are doing the phaco, whatever part we are dealing with is the 3.5 mm. So we do not really need to reach to till the depth of 3.5 mm. The nucleus which we need to crack is present at 1.75 mm. So we still have 1.7 mm of the base present. Now this is the safest zone where we need to do the phacoemulsification. Why this is called safe? Because it is deepest from the cornea and from the posterior capsule. It is also away from capsular axis. There is a more room for the manipulation. Now when does the posterior capsular tear happens? Mainly at the time of CCC extension, during the last piece of phacoemulsification, during IA, when we grab the cortex, when we grab the posterior capsule instead of cortex, during PC polishing and IOL insertion, though it is rare but it do happen. Now prevention. So how to prevent it? Keep the phaco settings low. This is mainly for inexperienced or the new surgeons. The aspiration flow rate, phaco power and infusion pressure should be low for the reduced pressure differences. Decreasing the parameter, especially during the last piece, is really important, especially in the posterior polar cataracts. Now irrigation and aspiration, we can have a minimal irrigation aspiration if we do proper hydro. Even if it is not done, then we can have a proper IA, but the tip opening should not be directed downward, it should be upward. Then if we tend to catch the accidental PC, that is a spider sand, we should move our foot pedal from foot pedal to foot pedal 1 just to leave the PC and check for the mechanical damage of the probe. Now what are the principles of management? Step 1 is early recognition. Pupillary snap sign as shown by the curve. Sudden deepening of anterior chamber. Improved reflex. Then the nucleus which was easily moving, now it is not movable. Sudden disappearance of the nucleus and nucleus tilt or subluxation. Now what to do in such cases is we analyze the situation, stay calm and composed, refocus, ask yourself what has happened, why it has happened and how it can be manipulated, and take the situation under your control. Now step 3 is the action. Decide to continue with phaco or convert to SICs. Now how it can be decided is the step on which the PCR has occurred, what is the amount of the nucleus which is remaining, the grade of the nucleus which is remaining, the other risk factor if sometimes the patient gets uncooperative, and the experience and the confidence of the surgeon. Now step 4 is stabilize the rent. So first stabilize the anterior chamber, you can put the visco, switch to lower fluidics if you are continuing with the phaco. Flow rate should be low, irrigation pressure and vacuum all should be low. Now step 4 is if the lens particle is still remaining inside the bed, remove the nucleus away from the tear, use the visco sheet, like you can put dispersive visco first beneath and then the cohesive visco upper. Then for the nucleus material displaced in the vitreous, do anterior vitrectomy and refer it to the VR surgeon. Stop fishing. Now if the epinucleus or cortex is still remaining, use the bimanual then coaxial to avoid dehydration. Dry aspiration should be attended and decrease the water height for the low infusion. Remove the cortex away from the rent instead of from the rent and catch the anterior fragment of the cortex rather than from the posterior capsule. Step 5 is anterior vitrectomy. Low subtenon block should always be given if you are taking a case in the topical anesthesia. Highest cut rate while the vacuum and the aspiration flow rate and bottle height should be low. Suture the wound and use preservative free triamcinolone just to stain the vitreous if you cannot see, and keep the vitrector opening facing upward to avoid the iris cutting. Bimanual is always better than the coaxial, and keep the irrigation above the cutter directed towards the angle to cause the laminar flow and prevent the vitreous hydration. Step 6 is IOL placement. So the many times we have a very small rent and there is no vitreous prolapse. We can keep the single piece IOL in the back. If there is a small PCR and we have converted the rent into a successful PCC, then also we can place single piece in the back. If there is a larger PCR, we should not place single piece, we should place multi-piece, 3-piece IOL in the sulcus with the optic capture. Insufficient capsular access support is there, capsular support is there, then we should go for either iris flow or SFI. Then in case of the dropped nucleus, we should do the anterior vitrectomy, clear the anterior segment, put the IOL, and then we should suture the wound and refer the case to the VR surgeon. Now back to sulcus IOL power calculation. So there are various changes. Since PCR happens on the table, so we need to decide what power of IOL we should put. Most common is the plus 17.5 to 27 diopter, and we should decrease it by 1 diopter. Then closing the case, before closing the case, always inject intracameral moxifloxacin dose 1 milligram and 0.1 ml, and relevant in a complicated cases because there are high chances of end-off. Suture the wound always. Post-operative management, oral antibiotic is important in such complicated cases. In the routine management, we can also add topical NSAIDs to prevent the post-op CM. This is one video. Where we can see at the time of the last piece of the nucleus, the rant has happened. This is little fast to save the time. So we can see the rent. This is a very small rent. It is in the shape of PPC. The case is proceeded with the phaco only. Now we can see we are placing dispersive visco over the rent and cohesive visco to maintain the AC. And in such case, we can place foldable IOL in the bag. So the another videos for the iris flow, but sir has already shown the iris flow videos. Thank you.
Good talk regarding this.
Now at last piece.
Yes. Yes, sir. Yes, sir.
So last piece was there.
Yes, sir.
And PC line was there.
Yes, sir.
To enter in.
Yes, sir. Sir, we have
rather than this manual, you can put the IOL scaffolding technique in which
yes, sir.
you put the IOL bag because the bag is almost empty. So you rather than doing this manual, you don't know. Whatever the process will take, it can as soon as you enter inside. That will go in. So rather than doing this, you can use IOL is called. It's very easy.
Yes,
you
yes.
are doing implantation, and then that part is above the lens, and then can you remove. That would be better thing.
One thing is that even if you are planned for one piece lens, always try for a multi-piece if available, because at the time of insertion sometimes things can go wrong, go bad, and then you can land up in IOL going into the vitreous cavity. So it is a safer bet to land an IOL over the iris and
Yes.
slowly tucking it into the bag. It is a safe bet. And it should be a slow process. And the other thing is the small piece could have been retrieved by a chopper or a dialer through main port.
One small advice also.
Yes, sir.
These are video-based presentations.
Yes, sir.
So all theory. This should be a video-based presentation. If you want the theoretical presentation, then there are a lot of topics like IOL calculations and different aberrometry, and lot of
Yes.
topics are there in ophthalmology. But these type of topic,
So I just want to share the pearls.
always do these type of topic video presentation, and there you can show that I am doing this. This is the PC, and then I am putting Triamcinolone on. Then now that's where. But in future you will.
One thing more was one thing more because okay. So Dr. Surbi, na? Dr. Surbi?
Yes, sir. Yes, sir.
So one thing more because what was is trying to say, जो दिखता है वो बिकता है. Because she's, but on your behalf, I am saying she is young. She want to use her videos only, so it will take time to collect videos. And one thing you have just told you, nobody tell. People are saying you should cover your PC rent with dispersive,
Yes,
but
yes,
nobody says you should remove that viscool. So it is always imperative to remove that visco, otherwise there would be uveitis and secondary glaucoma. So you go behind the lens and remove that carefully.
Okay,
Yes.
thank you.
Thank you, sir. Thanks.
You can take your certificate from Dr.
Now, this sponsor talk there. Dr. Vijay. Surely.